We're going to continue this great meeting with the afternoon of facial procedures, and we're going to start off with Jason Posner, who really is a world's authority in a lot of non-surgical modalities, both technologically as well as injectables and whatnot. And Jason's going to give us a whirlwind tour in 30 minutes, so welcome.
Thank you, guys. Thank you, Jeff and Peter and Bill, for inviting me. So just so you know, I do operate. I do this kind of stuff on my late afternoons and on my non-surgical afternoons where I inject. So, but I am in the OR the rest of the time. So disclosures, I pretty much work with almost all the companies, so I try to keep it equal. You know, the way I kind of designed this talk is I kind of want to pick a couple of technologies and talk about these technologies rather than run through everything that's on the planet, because that will take me more than 30 minutes. So these are the kind of things you plug in a wall that are useful for plastic surgeons for 2017. And, you know, a lot of this is borne out by data that's hard data. This is from AAPS data. Every year since 1997, they put this data out. And if you look at it, of the top 10 aesthetic procedures, 4 of them are device-related. So, you know, really, when you see these kind of numbers, you know, it's important that we teach our residents about these things, because when they get into practice, the patients are going to be asking them about these things, and you guys need to know about these things. So 4 out of the top 10 warrants our attention. So how do you start? Well, if you really talk to anybody who really likes this kind of stuff, we kind of break it up into things that are really important and that you're going to use, and doorstops. You know, because the last thing you want to do is spend $100 grand on something that's going to sit in a corner and not be used. So most of us kind of look at this and say, you know, the IPL devices, and if I say broadband light, one of the companies, Cyton, calls their IPL BBL, so it gets a little confusing. It's a marketing term. So really, I like to start with that. Laser hair removal, I think, depends on where you live. You know, in California, a lot of times you have these cheapo clinics, so it's kind of important to know about it, but it's really boring for us to talk about this kind of stuff. And I think every plastic surgeon needs to learn how to resurface. I'm going to go through that. Clearly, the first thing you should buy is an IPL device. You do a lot of stuff with it, vascular and pigment. You're talking about light in the visible spectrum up to the early infrared spectrum. There are different filters that you can use with some of the devices and different hand pieces that you use from other companies, and this determines kind of the light spectrum that you see. And what do you do with this? Basically, reds and browns are the easy thing. This is just BBL, another patient after BBL, IPL on the face. This is what you can expect after a couple of treatments, usually a month apart. Décolletés, we all do a lot of breast surgery, so after you do your breast surgery, it's nice to clean up the décolletés. And if you look at some of the texture changes that you can see before and after here, you definitely get some texture improvement with these light devices. Don't forget about hands, you know, very important. You know, Bill does a lot of faces, you know, and the patients have beautiful faces and lousy looking hands. So you want to try to rejuvenate them with injectables and lasers for color. So it's definitely important. And I do a lot of scars. We all create a lot of scars. So anything red in my practice gets IPL'd, and anything raised in my practice gets fractionaled. And there's a lot of data on fractional I'm going to talk about a little bit for scar therapy. Hair removal on light-skinned patients with dark hair is sort of the way to go with this. You can't treat darker-skinned patients or tan patients. But, you know, if you're looking at the whole hair removal spectrum, there's lots of stuff out there. I think that if you're really going to get into this, Alex's are the best, but when you're looking at darker-skinned patients, you need to use your ND-YAG laser or 1064, lower settings, multiple sessions. This is a case that Tony Wolf sent me, did a big rotation flap for a big skin cancer, and after that, we took care of some of the hair, so kind of a mix between the reconstructive and the cosmetic side of things. But with the same ND-YAG or 1064 lasers, we do veins. So big honker on the lip, that's a big vascular malformation. That's 2 treatments, and you can see that if you were going to cut that out, you'd have a big scar through the vermilion and possibly wouldn't get the feeding vessels. So that's just really easy to do. And I do a lot of dark circles under the eyes, which are primarily caused in lighter skin patients by increased vasculature, big veins coming in. So when you kill these big veins in these lighter skin patients, the eyes lighten up. So I do quite a bit of that in my practice. But that's kind of like the boring stuff to talk about. I really love talking about skin resurfacing. You know, when Jeff and I have been in this resurfacing business for a long time, back in the day when we had our old full field CO2 devices, it was on or off. These were your settings. You're going to burn the patient. It's going to take them 3 weeks to recover. They were going to be miserable for months, and they wouldn't tell their friends about it. The newer lasers are a rheostat. We can go from no downtime to significant downtime depending on your settings and your different devices. So 2 terms, full field, fractional. Full field is old school, like a dermabrasion or a chemical peel. You're taking off 100% of the skin surface area. You're healing from the bottom up, from your hair follicles and your sebaceous glands. This is full field, okay? As opposed to fractional. Fractional, you're treating an array of injury, and it's either non-ablative fractional or ablative fractional. So it's an array of injury. You heal from the bottom, you heal from the sides. Non-ablative causes a column of dead skin. That's the histology. Everybody see the dead skin in the middle. And then ablative basically chops a hole in your skin. So this is ablative, and that's the difference in histology. Very easy to understand between non-ablative and ablative histology. We all started with non-ablative, we kind of moved to ablative. The newest thing that I've been using, and Jeff and I were just chatting about this, is a hybrid laser. So it's a combination of ablative and non-ablative in the same hole. The question is why? And the answer is better results. We're seeing better results than we ever saw with non-ablative. And believe it or not, I mean, surgeon, I think, chop a big hole, you'll get a good result, but we're getting a better result with these hybrid technologies than we ever did with the ablative technology. Here's what the histology looks like. You get some coagulation in the dermis, and then you get a little bit of superficial ablation in the epidermis. And here's a comparison of the three histologies out there between non-ablative, ablative, and the hybrid technology. So the question is, now that we have these full field and fractional devices, what do you do? I mean, we have basically a lot of this is built in one platform in our practice, but how do you decide between one technology and another technology? Well, it's clear, like, I don't like to read my slides, but like, how bad do you look? If someone has deep wrinkles, they're not really going to get away with a minimal invasive technology in 2017. By the same token, if someone has very little pathology, you're not going to cook them. Okay, so you really look at what we do, and also, if they're in the OR getting a face or a tummy, basically we have the opportunity that the patient has a little bit more downtime. So if I see someone like this, I look at her and I go, well, you know what, you can dermabrate her, you can peel her, and maybe if you peel her deep, you may get some hypopigmentation. I can't fill her, because if I fill her, she's just going to look like she got punched in the mouth and going to have a fat upper lip. But to me, this is all day long full field erbium resurfacing. That's a 6-year post. I can do this consistently, and I can teach anyone here to do this in probably 10 minutes, okay, without getting hypopigmentation and without getting really prolonged healing. That's the new technology that we're dealing with in 2017 that's different than what we used in the past. If I see someone like this, I have a lot of options, and these are from a study that we did. So I would use a hybrid technology on her now because the healing is faster, she doesn't have a lot of pathology, and she'll be very happy that she can wear makeup in 1 to 2 days and look good within 48 hours. And that's what you look like at day 1 with hybrid, and no matter what settings you use, it's really crazy, you're healed by day 5 or day 6. And you look, most of the patients have makeup on at 48 hours. This is a new research interest that I have. It's called the VivoSight technology. It's optical coherence tomography, and it's used to measure skin. It looks at the first millimeter of your skin using a mid-infrared laser. Pretty cool. So that's that wrinkle in that lady, okay? And I looked at it, and then I looked at her and said, wow, that's pretty deep. But now you can actually measure it. You know, that's 230 microns deep, or 0.2 of a millimeter deep. That's a pretty damn deep wrinkle on her skin, isn't it? It's pretty cool. And you can also see the reticular dermis, and you can see the vasculature that's sitting in her reticular dermis. That's after halo. So that's a picture of halo with the dynamic scan and the structural scan, and you can see all the blood vessels. So now we're kind of using this data to kind of treat different things, such as redness with it. So that's a nasal vein in a guy's nose. I actually treated him with a ND-YAG laser, but you can see that's what the vein looks like, and you can see the depth of the vein, okay? And this is really cool. Look at the 3D reconstruction that they did of this nasal vein. Okay? So it looks at the first millimeter of the skin. So we're starting to look at applications for this technology. And in fact, in Europe, it's approved for non-melanoma skin cancer. So you can image a skin cancer, and then perhaps you can laser that skin cancer or treat it in any other way. So it's pretty cool. And we're kind of using this to kind of aid our laser treatments in terms of depth and densities and things like that. So in terms of the full field non-fractional resurfacing, like the lady I showed you with the deep wrinkles around her mouth, okay, I use this for eyelids. This is 8 years out after just resurfacing to her lower eyelids. So it takes a lot for me to do a skin muscle flap on the lower eyelids. The most I'll pretty much do is a pinch, and I'll definitely do transconj, just like in this lady, and she's 8 years out of a transconj, bleph, and laser resurfacing. So the results persist, you tighten up really nicely, and this is what my preferred use of a therapy for lower eyelids is. Perioral, I do this all day long. okay? Most of the time I do these now, deep resurfacing. If they're not getting a facelift, I do it under local anesthesia. Patients get a Valium, they get a shot of Demerol or a Percocet. I block their face, I put shields in, and I laser them. I used to do these all under IV sedation or general anesthesia, and I've switched almost 100% to local nowadays, and the patients are way happier. So that's an 80-year-old lady, okay, again, laser resurfacing a year out. This is a lady, I did her forehead and whole face. Interestingly, that her brow came up. I didn't do a brow lift on her. Okay, and that's her full face a year out. So I do a lot of this in the practice and tightened up her eyes. The healing times are not what you would expect. It's way less than you used to see with CO2. This is a 2-week out and about as deep as I go, and there she is a couple of months later. But they're not as maroon or deep red as they used to be with CO2. So the patients, these deeper cases have makeup on after about 10 days, and they're way happier than the ones we did 20 years ago when they were miserable for weeks and weeks at a time. So I do a lot of faces with lasers. That's just an early result, but I kind of just showed you that I don't do the neck. I don't laser the neck when I laser the face. I do deep on the forehead, eyes, and mouth, and pretty much a little bit in the cheek. And under the flap, I just do a little fractional treatment on the flap. I do a en bloc sort of smash platysma. I don't do a lot of cheek undermining these days. I do a lot more fat grafting and lasering to kind of work on the cheeks. I close with quills, and I do tumescent, so it's really clean. I don't really see a lot of blood. I haven't had any increase in any flap loss with the lasers. I've probably done a couple of hundred cases by now, so it's definitely a good adjunct to your laser cases. So that's our eyelids. Brow came up. That's another one. This is my favorite case. Facelift, fat grafting laser, obviously facelift for repositioning, fat grafting for the cheeks, and the laser for cleaning up the skin. So it's definitely something that you can add to your practice. You have to modify your techniques a little bit. If you're a thin cheek facelift flat person, I might not do as aggressive as I do. Okay, there she is. There's a lot of data now on scars with ablative fractional lasers. This is from a buddy of mine who's a Mohs surgeon in Denver, Joel Cohen. He lasered this patient twice, and you can see, interestingly, after his flap, basically the scars almost disappear on the face. So we do quite a bit of this on our surgical scars. This is a lady that came in to me. She was 80 years old, on Coumadin, a lot of medical problems, had a previous deformation of her nose from big cancer. And I just did a little fractional treatment on her that took like 5 minutes. And you wait a while, it's like watching grass grow, but they did rechange. He kind of reformed her face a little bit. So definitely something that you all should be having an interest in, because scars treatment has really become big business now. So a little kind of pictures on the hybrid that I showed you. This is one treatment with the hybrid fractional. Remember, this is about 1 day downtime. And in my experience with lasers, I've not seen anything with these kind of results with this limited amount of downtime. And this is the same platform laser that I use for the deeper erbium resurfacing. That's a Vizia picture showing UV damage. So actually, you can see his UV damage really decreased. Okay, pretty good results. Asian patients. The problem with lasers with Asian patients is they get PIH, or post-inflammatory hyperpigmentation. So with this, we're seeing really, really good results on our Asian patients, keeping the settings and the densities a little bit on the lower side. And there's a UV photo showing the amount of UV damage that's decreased. So that was step one, okay? A little bit of IPL, a lot of resurfacing, because I think every plastic surgeon should be doing resurfacing. Now kind of getting into, for the next 15 minutes, kind of step two, which is a little confusing because you have a lot of options to choose from. But I'm going to try to narrow that down. Let's start with non-invasive body contouring. These are the devices that are out there on the market that we use for non-surgical fat removal. Cryolipolysis, which is cool sculpting. Ultrasound-based, which is both Syneron, the ultra-shaped device, and the Salta device, which is part of Valiant, that's liposonics. Cynosure on sculpture, that's a laser. Vanquish is made by BTL, that's a full-field radio frequency device. And of course, everybody should have Kybella in their practice because that's owned by Allergan. It's easy to squirt a little bit in your face and some other off-label areas. So cryolipolysis, the interesting, if you've never heard of it by now, it's kind of strange, but it came about because Rox Anderson and Dieter Mancine, derms from Harvard Labs, they found there were 2 cases in the literature. One was popsicle paniculitis, meaning a child sucking on a popsicle lost facial fat. And 2 was a woman riding horseback in England lost some thigh fat because of the chill. So they reasoned that there was some relationship between cold and fat loss, and they developed this device, which has been out since 2010. It's a device that suctions the fat between these two metal plates. It chills it to just above freezing, and some of the fat dies. Jay Burns did a nice study on this. It showed 22% of the fat in that area died. And here's the histology. You kind of get this programmed cell death over a couple of weeks, and by 90 days, the skin looks normal, the fat looks normal, it's just less fat there. There's no impact to serum, lipid, and liver functions. And this is what the FDA had a big problem with initially with any of these non-surgical fat removal devices. But basically, they got over it because there were no changes. And Jeff's lab at UT did some of the initial work with UltraShape with a lot of the serum lipid levels. And they showed that there was no change in serum lipid levels after treatment with the UltraShape. So the results of cryolipolysis are really durable. It's FDA cleared for these areas. So that's what the device looks like. Has an applicator. There's a gel pad that protects the skin. It goes on. It's really comfortable. I've had this done to myself. There's a bunch of different applicators. Within the last year, they came out with this new applicators that reduced the treatment time from an hour to 35 minutes. So that's the fastest treatment time. It actually works pretty good. There's no change. You do flanks with it, abdomens, okay, abdomen. So it works really well. Thighs, chest. You can do gynecomastia. That's Grant's picture. Thank you, Grant. There's a Cool Sculpting Mini that's used for the bulges. This is just showing you what your neck looks like with that. MRI result. So it really works well. This is Cool Sculpting. Okay. Now, I still think, I'm going to say this again, I still think that the Cool Sculpting device is the best non-surgical fat removal device out there at this time. But these are some of the other devices. UltraShape, and Jeff did a lot of the early studies with this. This is the VD, kind of the variable focus one. There's a new one is out now that's called the Power that I don't have any experience with. So this is a focused ultrasound device. It's focusing the ultrasound in different layers. And this is sort of some fat. You can see what the difference between the original, which was single focus, and the variable focus. It kills the fat and leaves everything else intact. Here's what the EM electron micrograph looks like. And there's an MRI, or CT scan rather. And here's some of the results of that. You know, we have this, we did a study with them, and it seems to work well on high BMI patients, but I still think Cool Sculpting is more efficacious than this. The Liposonics device is kind of a dud. This is by Salta. It was initially interesting because it was only one treatment. It actually was a little different focus. It was thermal coagulation of the fat. You can see it burned the fat. It worked really well. It really didn't get a lot of consumer report because it hurts like hell. Okay, so really anything that hurts, people aren't going to gravitate towards, even though it was efficacious. So this is pretty much still sold, but I don't know anyone who's bought one of these within the last 5 years. Sculpture is the newest device out there. This is by Cynosure. This is a laser. It's 1060 nanometers, so like sort of similar to the Nd:YAG. It's got cooling on the skin. It cools the skin. It puts the energy into the fat cells. Now remember that fat is susceptible to both hot and cold. Cool Sculpting is the hot. Cool Sculpting is the cold, and this is the hot side of things. It basically burns it, gets to a level where it's getting controlled cell death. So it works pretty well. It penetrates into the fat. The studies were really good. Larry Bass was one of the guys doing some of the initial studies with this, and they were super clean. The tissue responses were good. All the histologies were good. The MRI was excellent. The results are good. But in clinical practice, we don't like it that much. We have one of these. We think it's better on the thinner patients. We found it a little inconsistent use. We still like our Cool Sculpting better. This is another device that I was really hot on a few years ago called the Vanquish device. This is selective RF. Basically, you're heating again to control the fat. I liked it because you didn't touch the patient. You put this over, let's say, their abdomen. It created a nice thermal profile, and the studies were good. But in our hands, it didn't work. We had very bad results with it. That was the initial device. They just gave us a new one to play with, so I don't have any data on the new Vanquish, but I will have some data probably in a couple of months. But we're a little hesitant now because of our bad experiences. And I was super hot on this because I love the concept, but I learned to be a little more careful after that fiasco. But we'll see how the new one comes in place. Everyone should have Kybella in the office, deoxycholic acid. This was a company that developed it called Kythera. They got bought by Allergan for like $2 billion. It's an injectable for fat removal. The studies were super clean on this. The FDA-approved place for this is the submental area, and the studies were great, and that's me after Kybella. You swell like crazy after this. I mean, I look like Alfred Hitchcock in the picture with this, so you do get a lot of swelling. But I looked at my pictures. It actually seems to work pretty well. So these are my recommendations for non-surgical fat. I still think if you're going to buy one, you're better off with cryolipolysis. I still think it's the best thing. The problem with it is, though, 1 in 4,000, instead of losing their fat, gains some fat. So you'll see patients in your practice every once in a while that have fat growth from this. If they do have this, you contact the company, you do liposuction on them. I like to use my Vaser or ultrasonic lipo because the fat's a little firmer than normal fat, but it gets off, you get rid of it really well with the ultrasonic lipo. And then Zeltiq company will pay for the patients to have their liposuction. So if you see one of these, don't get too stressed, just call the company and they'll deal with it. But that is the problem, 1 in 4,000 does get that. Sculpture, we're still playing with a bit, and I think everyone should have Kybella in their office. I saw Instagram that someone sent me yesterday that somebody was using a dermatologist for Kybella for the arms, and they were just injecting in the arms. I've used this off-label for nasolabial folds. I've used it in every area you're not supposed to. The initial studies showed some nerve injury because I think the dermatologists that were using this didn't have any idea as to nerve anatomy, and they were putting it in the wrong spots. So I think if you stay superficial with it, you can use it off-label on the face in areas where there's superficial nerves. But people are using it for liposuction bumps here and there, and I think it's actually really good to have in your practice for that. So easy to use, easy to learn. So let's kind of switch gears a little bit into the last topic of non-surgical tightening, okay? This is the area that's a lot of hype. There's so many different companies talking about different technologies here and there that it does get a little confusing. But the patients want this. This is data from Real Self. Look at the views on this, 1 million page views looking for non-surgical. Why? Because I know I can get a good result with a facelift, but think of how many patients out there that want a facelift but just don't want to go for it. They don't want to have the surgery, they're afraid of the scars, they may not could be medical candidates, or maybe they're ready for a facelift in 5 or 10 years when they're 55, but they're now 45 or so and they want to get something done. So this is where some of these non-surgical technologies come into place. We know that what you do with the face, you reposition and get rid of excess skin. You don't really do anything to the skin quality, and that's where a lot of these devices can work because they can be synergistic. So why should we be interested in this? You can read this, right? It's definitely a facelift alternative for some patients, and I think in the future as things get better, it may put our facelifts out of business. So if we're going to be out of business in 10 years or 20 years from this, don't you think we should be the ones doing this? Look at the way that interventional radiologists have taken over for cardiothoracic surgeons. I want to be at the forefront of this. I don't want to wait until some other specialty, notably dermatology, takes this away from us. That's why I'm involved in this. So here's the mechanisms. Mostly it's through heating. It's from a heat shock protein mechanism. So you have these heat shock proteins. They cause a collagen remodeling response. So I classify these as outside in, things we do outside, or things we do inside the skin. The inside are sort of like lipo cases. The outside are either lasers or pulse light or radio frequency. I'm going to go through a few of those in the next 7 minutes. So external tightening. This has been sort of my favorite thing for the last year or so, fractional radio frequency microneedling. So we all know what microneedling is. You take these little needles like rollers, you roll it on the skin, and it's good for some acne scarring, it's good for some skin rejuvenation. So what the companies have done is they put some energy at the tips of these needles or throughout the whole needles depending on the device. And this puts down a little burn zone histologically in your deeper dermis. So typically with lasers, we're talking about 100 microns, 200 microns. With these devices, we're talking about millimeters. So a typical session for me treating someone's face, I would be at 2 millimeters or 2,000 microns, a second pass at maybe 1,500, and a third pass at 1,000 microns. So we're deep into the reticular dermis with this. There are two different sort of classifications, either energy just at the tip or energy throughout the whole needle. And the histology is a little different depending on which one you use. And there's a few more companies out than I have listed here. This is the insulated needles, meaning that the burn zones are going to be deep unless it's really superficial, which like the 0.5 millimeter, you get a little bit of epidermal injury. This sort of looks like the hybrid laser histology, doesn't it? But you get some tightening with this. And this is the non-insulated needles. Basically, you get like a fractional ablative laser. You're getting a deeper burn zone. So with the non-insulateds, you definitely get some epidermal injury. So in the wrong patient, someone who's a little darker skinned may not be the thing you want to do. So I kind of like the insulated needles. And this is the Infinity system, topical anesthetic or a nerve block, super easy. Usually 3 treatments, a couple of weeks to a month apart. Okay. Pretty straightforward, easy to use. Intercell is another company. So what's interesting is both the Lutronic Infinity and the Intercell are both Korean companies. I think there's a little patent infringement, and I hear that the two owners play golf together, so they're not really fighting with each other. But they're very similar technologies. We actually have both, and I really can't tell you which one's better, but they're really similar with a little disposable piece. Cineron Profound is another one. We had this. I really don't like this. It goes in an angle. The needles are a little bit bigger. So I kind of like the other two insulated needles. These are some of the results. You get a little tightening with it. Nothing that impressive, but the EndyMed's another company kind of showing you. You get a little red, but they really heal super quick from this. Dr. Clementoni in Italy has done a lot of work with this, with some really good tightening in some of his patients. But note he treats these patients pretty aggressively. But you know, for the pre-facelift crowd, it's pretty good. This is our preferred treatment for acne scarring. I think for acne scars, there's nothing better than microneedling with energy. There's another one. Here's another one within one of the other cases. So this is our treatment for acne scarring. This is a lady that I did a facelift on, and you can see her scars, just post-auricular area, but she had a little bulging in her neck, like a little fold of skin. So I treated her. So it kind of uses for touch-ups of different areas to tighten up some things. So external RF, that's sort of the microneedling component. I have 4 minutes left. So when you look at radio frequency, these are devices that heat up the skin. So they were selling these for cellulite, they were selling it for tightening. I don't know. I kind of like it for post-liposuction smoothing and a little bit of tightening. This is a new device that's just came out recently. It's radio frequency, but it's got unfocused ultrasound built in. So we like this post-lipo. If you do a lot of lipo, you should really look into this stuff. It gets you a lot of smoothing. It gets rid of some of the early scar formation and kind of smooths things out. So that's an external ultrasound device. We all know what Ulthera is. So this is another external device. This is ultrasound based. It puts a burn zone deep down with ultrasound energy, focused ultrasound. Sort of the histology looks like the micro-focused needles, doesn't it? Looks really similar. You image, it then comes down as an ultrasound device. Okay, problem is this device hurts. The results are okay. In my mind, I like the microneedling better than Ulthera. We have this. We do very few Ulthera cases now. We do far more of the microneedling cases. It's way easier. But you get some tightening in younger patients from it. That's the external. I'm going to end with internal tightening. So these are sort of lipo devices. So Barry DiBernardo did most of the early work on this, a good friend of mine, with skin shrinkage and elasticity. So he started with lasers. That's one technology. He measured the temperatures both internally and externally. And we use the Precision. This is the smart lipo device. They have one of their probes called the Precision TX. It's sort of a unidirectional laser probe. Use it in the necks. And the results are pretty good in younger patients. So this is one technology you can use. Now, if you have a smart lipo device, you should use this because it's easy to do. It's done mostly under local anesthesia. And for younger patients who have a little bit of neck laxity and a little bit of fat, it's a nice procedure. That's one of Barry's cases. I tend to use more of the radio frequency now, and we have both the Thermi and the Invasix. Thermi is monopolar, Invasix is bipolar. I was a big Thermi fan for years. I've had it for a while. I was part of the Invasix FDA study in 2010, and it finally got approved recently, so I've been using their newer device now. It's using radio frequency energy inside out to tighten skin. This is the Thermi device, which is monopolar. It basically kills a little fat, heats the skin from the inside out, but you're measuring the skin externally with a thermal camera. Good data on this stuff, really nice papers submitted, and this is actually the body type or the face type by Invasix. This is bipolar. So instead of having just a monopolar probe in with an external return, this has the return on the face. What I like about this is it's actually measuring the heat both inside and outside at the same time. It's pretty easy to use. This is one of Barry's cases with the Thermi. This is one of Barry's Thermis. This is my first radio frequency case with a new device on a friend of mine who's 50, had done it under local anesthesia, and she's a month out. I find it a little easier to use than the Thermi. I mean, it takes like 10, 15 minutes. It's a good ROI. So it's a really nice device, and I like the fact that it's very controlled. Barry's been working on breast lifts with the Thermi device, or the monopolar radio frequency device, and that's one of his pictures 3 months later showing a rise. And Diane Duncan's also been working on this with some of the RF devices. So I'm just going to end with this. So my tightening recommendations, I kind of like the microneedles, especially for acne scarring. I like the RF internally. I like some of the RF devices post-lipo, but the problem is if you're going to go buy all these devices, it's very hard to figure out which ones you need in your practice. Start slowly. Most of these things last years and years in your practice. I don't want you to buy any doorstops, and if you have any questions, please feel free to email me or call me. I'll be happy to guide you along with some of the companies. So remember to start with your IPL and then resurfacing cases, and then go from there, and don't be waylaid into buying stupid things that the companies talk you into. Thank you very much.
You can have a seat. Yeah, okay. We'll call you back up for the Q&A. Okay. Okay. Thanks, Jason. That was a whirlwind tour in 30 minutes. And you weren't even talking as fast as you normally do. That was good. That was good. Next, Bill Little's going to come up, and he has really taught us so much over the years with regard to facial rejuvenation, and he's going to enlighten us on how we can get better results with our blepharoplasties.
Yeah, Jason, that was a whirlwind tour. Imagine when he gives his full tour. Can you believe it? So thanks, Jeff. I'm using the word blepharoplasty in the title, but just like Jason, I don't do blepharoplasty so much. He loves laser, and I love fat with laser, not as sophisticated as Jason. So, but I'm going to also get into blepharoplasty. I'm going to show you how I think I've modified my technique a little to make it simpler and more predictable, but a lot of this talks on fat. So go ahead, Tracy, hit my button if you would. So it's volumetric rejuvenation of the orbit, no conflicts, and I sort of put the eyes at number 3. I know you don't all agree with that after the mouth, but in any case, upper and lower orbit are pretty equal for me in terms of importance. Yeah, I was afraid of that. Something we've had, well, all right, that's not important. If it's only one, we can live with it. Good. So traditional rejuvenation surgery is an effective accelerant, of course. This is an old 20-year-old slide. Or why wait until you're 70 to have a drawn face and hollow eyes, if you can afford, etc. So it should not surprise us that the history of facial rejuvenation surgery has been one of excision because, of course, the history of surgery has been excisional, and this is nothing new. But the time has come to abandon the traditional operation that we've called blepharoplasty, which has really been a blepharectomy, and time to embrace a paradigm shift away from excisional surgery, at least around the orbit, towards augmentative. And of course, that's a about face, and everybody in the audience has probably made their about face a while ago. I made mine a long time ago. And as Sidney would say, the principle is that fullness equates with youth, and if it does so more around the orbit than anywhere else. When I study the face and try to decide whether I'm going to lift or fill, I compare suspension with augmentation, and only in the orbital zone does augmentation trump suspension. Everywhere else, I want to suspend first and then maybe augment a little. In other words, the needle is much more powerful than the knife, and I still believe that was a paradigm shift for me, at least, some years ago. And so when you look at the puzzle of volume around the eye, think of this balance again. And on the nasal side, think augmentation. On the temporal side, suspension, because nasal volume undergoes volume loss, whereas temporal volume actually descends and can be resuspended. Medially, it's as much bony as it is soft tissue, and often the medial brow goes up with it. Of course, the lateral brow drops. So does the orbicularis and the malar mound. Those aren't suspended except by a raphe, as you know. Trying to lift things medially in the upper doesn't make sense. You've really got augmentation. You can share your fat, of course, in the lower lid, and many do, but I think it's far easier to augment, and it's more effective, too. I continue to suspend that one quadrant, the upper outer brow, but I rarely do mid-face lift, virtually never, and I only do lower bleph in 20%, so 1 in 5. So I'm really relying on augmentation as my key tool in 3 out of 4 of these quadrants in terms of rejuvenation of the orbital zone. Now, there's not time to get into a lot of fat grafting principles. Peter covered an awful lot of important things, but I'm going to drop down to under placement, which is the most important thing in my book, technique, and I'm going to let you know red and green when I agree with Sidney or not. So I use microneedles for most of my fat injection. I think most do now, and I inject with blunt needles. We all pretty much agree with that for the most part, except there is a role for 23 gauge sharp, which I use for lip lines in a few places. I inject with my hyperthenar eminence and not the thumb. I think it gives more control. It's a more even measured injection. So I use only 1 cc syringes, but half full, because if you fill them up all the way, you have to use your thumb. And I inject coming and going, and so does Tim, but Sydney decidedly doesn't. And we heard earlier that inject minute amounts per pass. That's the single most important lesson in all of it. We heard that from Roger. Inject in multiple vectors for the most part, inject multiple planes for the most part. I don't in the orbit, which is all deep, a few places. Pre-tunnel, when you do a superficial injection just under the skin, makes it easier to be uniform. And inject across linear deformities, not along them, and it's especially true for the tear trough and the labiomental groove, but it's true for a lot of things. Inject always with epinephrine. It decreases your ecchymosis, but embolism risk, very important. We ought to be doing that. Minimal pressure. Never try and force this fat because it's a prescription for disaster, particularly embolization, but also fat lumps and irregularities. Constant motion. Roger brought that up too, and it's absolutely right. Never static. If you're moving all the time, it's pretty hard to get an embolization. So preventing blindness, we can't go over this enough. Blunt, minute amounts, vasoconstriction, minimal pressure, and constant motion. It shouldn't happen under those conditions. In terms of the sites, recipient sites, I'm just going to talk about the periorbital zone. So what are the things around the orbit that I'm going to fat graft? Well, first of all, in almost everybody that I see, the suborbital zone, and medially 3 centimeters. Rarely do I go above it. Rarely do I do much less than it. It's deep and intermediate. Lateral, the same, maybe slightly less in terms of the volume. Deep and intermediate microfat. In the glabella, yeah, pre-tunnel, and this is superficial. I usually don't exceed 0.5. It's very easy to overdo, at least in my hands. Your temples, sure, it can take a lot up to 4 or 5 cc's even. That's superficial grafting for me, and I only do it in 25%. Others are more apt to do it. The brow roll, important. I don't like to go over 2.5 in one session. I do it, if I'm doing a blepharoplasty, which I almost never do in the upper lid, I do it after I've done that. So those are my averages, about 15 to 20 per patient fat graft in the orbital zone. It's a part of every facelift that I do. I don't put fat in the face so often, but I put it around the eye in everybody. So the upper orbit, we're lowering the lid fold, and often, by the way, the nasal brow, head of the brow. From the suspensory point of view, what is it that I'm suspending in the upper orbit? Well, the orbicularis muscle. It's the way I look at it. And that suspension, I use the verb hitch or noun hitch, and it's a superior temporal action. I don't want to have really almost never motion to the medial brow, very rarely. So it's a selective in that outer upper quadrant. And the temporal hitch is the term I use to kick up the tail of the brow. And when I do a brow hitch, I'm really trying to lift a brow that's significantly low and often fixed, and that means freeing down to the orbital margin and then dividing the arcus marginalis and getting that to move upwards. Rarely I divide the muscle twice, as Steve Burge talked about, and then do a lateral elevation. I need a screw in 5%, 95% the fascia suffices. But when I'm doing vertically directed facelifts, I need to do something in almost all of those because I don't like to use a pretracheal extension of my scar, so I'm stuck having to lift that part of the scalp. And sometimes, by the way, I use more and more, I use a scalp excision to help support that, but I don't like to use the pretracheal, which many do. And and then a while ago, we saw a lot of these eyebrows up in the middle of the forehead. That's a lot less common now. I think we've become aware of this, but there is a technique to lower that. Mike Yaremchuk's talked about it. He does a coronal. I just do it through little incisions. Here's the first one I did years ago on a board-certified plastic surgeon. This woman didn't need her brows elevated. She lost her folds even in the process. And so I learned how to lower these things by freeing the entire scalp, subfrontalis galea, and bringing it down and fixing it with a screw. So brow elevation, if a little is good, which it is temporarily, of course, more is not so good, and a lot is usually dreadful. And I think everybody in this audience, I think, accepts and understands this, and it's a bizarre look that harkens back to the 50s. So brow lift, yeah, I don't do it so much. I think of the brows as having two components. There's a temporal brow that descends predictably, and if the nasal brow moves, it more often moves up than moves down. Sometimes it doesn't move. So I think in terms of a brow tilt, if you will, and certainly kicking the outer tail a degree, lowering the inner brow. It's a rake, if you will, which is just an inclination away from the horizontal, like wearing a kepi or something in the Army. And there's Anna Nova again, which we saw, and she certainly has that. She's a composite of 3 of Britain's most beautiful women, Kylie Minogue and Beckham and others. Lowering the lid fold by fat roll grafting. That's the most often the way that I choose to do it. This is a 70-year-old, had prior blepharoplasty, and you can see that her eyelid opens at the same time that the lid fold drops a little. The brow doesn't change, but she looks pretty young for 71, and that's because of fat. Here's an iatrogenic case where someone's attempted to make an Asian woman appear European, I guess, but it didn't go so well. And here her brow is dropping with the addition of fat, and her lid level is dropping too. So there's some interesting things that go on if you use this fading technique that Val has pioneered, and it's so useful in allowing us to see small motions which otherwise would escape our detection. There's a woman who came in, she knew it was wrong, her tarsal displays way increased, and she said, they put my eyebrow too high, and all I did was lower her eyebrow to correct this. And of course, that's another way to approach lowering the lid fold. If the brow's been set too high, you can lower it, as you see here in this early result. And lateralizing the eyebrow redistributes the volume within the upper lid brow's combined structure almost always in a positive way. And that was all that was done here. She had fat grafting the lower lid by a block graft, but no injectable fat anywhere. That was before I was doing that, and you can see the improvement. Okay, so upper blepharoplasty for me is hitching often the scalp, often the brow, but always the scalp. I'm going to do micro fat graft of the central medial, particularly the V deformity that's against the bone, is a bony augmentation. I do conservative laser resurfacing in 95% of them. I use old-fashioned equipment. Conservative skin excision in just 5% of my patients, and then medial fat reduction less than that. So I'm not touching the bleph in 95%, so I can't call it a blepharoplasty. It's an orbitoplasty. Now, what are the effects of manipulating the brow on brow posture and upper lid architecture? Well, first of all, if you do a hitch, of course, you get a change in your brow position. That's direct. And the same way, if you free up and pull the brow down, you're going to lower these high brows that are usually iatrogenic. Temporal hitch may also lower the nasal brow by breaking a lifting reflex of the frontalis. And as I mentioned, lateralizing the brow is generally a good thing. It just helps redistribute in an artistic way the volume there. And then temporal hitch with fat grafting and laser usually precludes blepharoplasty, at least for me. As I said, I'm doing it in about 5% of my patients, and 95% I'm not. Now, I don't have an older patient population. That wouldn't be true if I did, as many, particularly oculoplastic surgeons do. But this woman had brows set too high, looked everywhere, and we lowered them by the technique you talked about. I just talked about. This is another one of these, but hers was not iatrogenic because it was developmental, which I found to be quite unusual. But there she is, just quite a young woman with this strange stare. And these are very hard to improve, but you see how important it is to improve them. And then another one that was iatrogenic from a board-certified plastic surgeon. And again, when you look at, don't just look at the amount of distance that those eyebrows have moved from her postoperative position, but look at her as a young woman. She'd had no surgery in her life before she had that procedure done by him, and look how much movement he imparted to the brow. And then a temporal hitch raises the temporal brow. Sure, it does it, of course. And usually it makes upper blepharoplasty unusual, at least in my hands, or unnecessary, as in this case here. Why would I want more pretarsal display in her at her age now than when she was a young woman. And of course, it's important to study your patient's early photographs so you understand where that base point was. So what are the effects of my fat grafting on my upper lid and brow postures? I'm going to take you through some of this, some interesting things. Number one, you lower the lid crease, period. And then these adverbs are important. It usually lowers a high nasal brow and often improves the lid level when the lid's too high or too low. When it's lid's too high with a stare, it usually lowers it, interestingly, and it may raise a low lid, almost as if you'd done some ptosis procedure, in a way that's auto-correcting by mechanisms I don't understand. I've thought about them a lot, probably complex reflexes of some sort. And finally, fat grafting to the temporal brow may raise that structure. Somebody showed an example of that earlier today. So let's look at a quick picture on how I graft the upper lid. I mark the area, again, just the central medial, not lateral. There I take out the 20-gauge needle that pokes my hole, and then I'm using a micro needle, and notice that, again, once it's settled and it's right against the bone, I'm not using my thumb but my thenar eminence. I'm moving constantly, but the plunger is moving very, very slowly. Think of what Roger said about the rate of injection, and I agree with him completely about that. It's especially important in the large volume fat graft. So fat grafting lowers the lid crease, and it certainly did in this woman. She's had no upper blepharoplasty, only fat and laser. And in this woman who's had no surgery to the eyes in any case, only fat grafting and laser. And in a relatively young woman, it can be quite important when these very, very open, recessed upper lids look old and debilitated. Here's a woman, iatrogenic. She's had a lot of bad things done to her, but they've taken all the fat out of her eyelid as well. And usually we can get that back to what was there before, just as we can in the case that develops spontaneous with aging. Here's another case, much overoperated upper and lower lids, and again, the fat grafting is very important, and we can get things back pretty well. So, lowers the lid crease, but it does something else. If the brow's high, notice that the medial head of the brow is dropping down, not by anything I'm doing, except the placement of 2.5 cc's of fat. Now, as a young woman, she had a low brow, typical. I haven't gotten it that far, but I've moved it in that direction, and you can see how much she elevated just by aging alone. So again, it lowers the lid crease, fat grafting does. It lowers the medial brow if it's high, automatically, and not as much as when she was very young, but it gets us going in that direction, which is appropriate for her age now, and see how much her brow elevated just through spontaneous aging. Another example, lowers the crease, but in the case of high-line brows, it often, in an auto-correcting way, lowers that structure. I don't control that. And it gets her much closer to her early appearance in youth. And I don't know how else I could create that effect. Secondary case lowers the lid crease after the prior blepharoplasty, and then lowers the, the brow position as well. And it's important even in younger women in whom the motion isn't so much. You can see that nothing's been removed from that medial fat bag. It's just been blended by adding fat. And yes, as a young woman, it was lower still, but this is a worthwhile direction in worthwhile movement in that direction. Another young woman filling that empty V deformity upper space, dropping the brow as well. Remember, that's a 3-minute procedure. It works as well here, lowering the fold, and whether there's hair in the eyebrow or not. That's just a tattooed brow, of course. It doesn't make any difference. So, lowers the crease, and it usually lowers a high nasal brow position, but it may do something else. It may raise a low lid. Now, here the verb is adverb may. You can't count on this, and I'll show you examples where it didn't. This patient had only fat grafting. She had nothing else, and she shows up 10 years later at 44, and look at the effect on her aperture, her pretarsal display, her brow position, all from that fat grafting done that long time ago. But it doesn't do it always. This woman, her fold is lowered, and her high brow position has come down. She didn't want any cut on her upper lid, so we didn't reduce her medial fat pad. But she has not changed her eyelid position at all. So again, the operative word there is may. It's just where it was when she was a young arrival here in the United States. So it lowers the lid crease, fat grafting lowers lid crease, it lowers the medial brow position if it's high, and it may raise the lid. And this is much more typical than those more dramatic ptosis-like corrections, but just an opening of the eye. Again, you see the full drop. The eyebrow isn't going to change. It's not high, but her eyes open a bit. It looks like 1.5 millimeters on the temporal quadrant, maybe 1 millimeter in the nasal quadrant. And that woman I showed you before with the very empty eyes at 48, her brow position doesn't change, but her eyes open more. So I see this a lot when you do a close inspection of your results. I see that it happens often, and it does so just on its own. If it's too high, it many times will lower. If it's too low, it sort of raises. So there you are. You can explain it. I can't. I'm just reporting findings. And so she looks pretty much like herself, and there's nothing wrong with that as a young woman. I mean, again, I think most of us would do a blepharoplasty. I didn't. This is fat only with laser. And again, you see the lid crease drops, the nasal brow drops, and there's a little bit of opening in this woman in her 60s that is probably positive. The lid fold drops. Now here, this hasn't lowered a relatively high eyebrow. It's come up. So these rules aren't ironclad. But it's helped her with this buggy quality she's had most of her life about her eyes. And I think fat grafting is the best approach to the buggy eye that I've yet been able to discover. Here's another buggy eye. Now here the upper fold is dropped. The medial head of the brow is dropped. But this time, the eyelid level is dropped, at least in its nasal quadrant above, not so much on the temporal. And again, it happened automatically. No fat's been removed from her lower lids, by the way. That's done simply by adding fat. This patient has a stare. She doesn't have thyroid disease. She's unaware of it. But her fold comes down, her medial brow comes down, and her eyelid comes down enough to cover her corneal limbus and alter her white temporal triangle. So this is usually, because I find this more often than not, it will have this effect. I think the more predictable the lowering of the wide eye than the lifting of the narrow one. This guy said people at work say I'm too intense. Well, it's it's a stare, of course, that gives them that intent look. And again, fat grafting alone has helped that. And it's interesting what 1 millimeter or 2 can do, of course, to this kind of a impression. This guy had some minor adjustment to his eyebrow, and when he went home, he said, "Nobody recognized me at Christmas. My mother cried." Well, all that happened was he had a stare unmasked. He'd probably had it for years. So fat grafting alone gets him back, and he's happy, and his mother's okay again. Now, medial brow, lid fold down, medial brow down, and again, the medial. Now, you notice she still has a bowing out there, and that's my failure, but she's still much better off, and the fat has done most of that work. It's not infallible. I wish there had been more improvement in this particular case, which has a lot of stare. She really is over the limbus quite a lot, but it's still to a worthwhile degree. The other side looks very good, but this extreme case it doesn't as much. And again, no fat grafting to the lower, no fat removal from the lower eyelid bag, simply camouflage fat grafting. And again, this woman who's having some things done, and I'll get back to her, her eyebrow raised simply by grafting the temporal area, and Sydney has said that was possible. It's not the way to do it. I think there are more controlled ways to do it, but there you are. So temporal hitch raises the temporal brow, and many times with fat grafting and skin resurfacing, you can avoid a blepharoplasty scar altogether. This is one in whom I divided those muscles a la Steve Bird, and also did some micro needle grafting with a 23 gauge needle and got her forehead under control. So what about the lower orbit? Well, it's a little bit the same thing. The lower orbit, it's raising the apparent lid-cheek junction. And once again, we compare suspension versus augmentation. Augmentation trumps. It's much more important, I think, than what you do of a suspensory excisional nature. But I've tried to at least make it easier, so I'm going to share with you my recommended lower blepharoplasty technique. Even though I'm only using it in 20% of my patients, I'm relying on fat for the rest. What is it again that I'm going to lift in the lower? Same thing, the orbicularis system. It's an orbicularis suspension or hitch, which is purely y-axis or vertical. I do it in 20% of patients. I don't bother if it's only 3 or 4 millimeters unless the patient's really particular. Then I might. It's a buttonhole after you remove the skin, and then you hitch the bottom border of that muscle up to the lateral orbit. This is not an internal stitch near the tubercle. It's just in the in the periosteum. I free the skin a small distance, and if there's still laxity, you can advance the lid margin toward the nose and often avoid having to do canthal procedures or lid shortening procedures. That's a little complicated to get across in a minute or two, but I'm going to try. I use a tarsorrhaphy every time I do a lower lid incision. For 20 years, it just eliminates problem chemosis. So when you do an abdominoplasty and you sew it up in the middle and then head out, you're going to get a dog ear every time. Every experienced surgeon knows that, and it often happens. It certainly happens in this. You're going to remove 10 millimeters from the lower lid, and you start sewing at over by the nose at the caruncle, and you end up with a gap or a buckle over there. It's a ruffle, really. That's what happens when you sew a loose edge to a tight edge, and most of us understand this in plastic surgery. We know in the abdominoplasty that we have to pre-position that disparity, so we put a few stitches in, and then we don't end up chasing a dog ear. Well, it's the same thing in the eyelid. It took me years to understand that, appreciate it. But if you, in the laxer lid, because it's the pretarsal segment that's lax, that isn't involved in my blepharoplasty procedure. If you redistribute that laxity, you can usually avoid needing to get into the lateral canthus at all. Here's a patient, I've shown her she's had prior surgery, she's got sclerotial, but look how much the skin marker moves, her nevus down there, even though somebody would say, oh, she's had too much skin removed. No, typically that's not the case. It just hasn't been supported and hasn't been done right. So that's done by simply hyperplacing the position of the suture as I do it. Now, just as we have a premasseter space, of course, before that, Brian and Bill Adams and Musafar described the prezygomatic space, and that's why there's no need to ever free anything or to release anything. I think that's a fallacy. And the 5-0 nylon suture is all that's necessary to resuspend that fallen orbicularis. And of course it falls. There's no muscle origin like there is medially. It's just a raphe that moves easily. So this is y-axis, but do I ever do x-axis? Sure. If the patient's really got a horizontal lid laxity, which I consider when it's about 15 millimeters of distraction, which is really a loose lid, then I just put a suture in the terminus of the tarsus, and this time it's an internal stitch near the tubercle and draw it over. Not all the way. I leave a spanning suture. I just want to get the distraction down to 3 to 4 millimeters. But I don't need to do that very often. I say 2% up there, and I'll share those statistics in just a second. So that the 3 evaluations then, lid distraction, snap test, vector analysis, I only use one in the execution of this procedure, and that's lid distraction. It's the key thing for me. And so I'm going to start off. If it's over 15, you're going to need to shorten the lid somehow, tighten it. But if it's less than that, of course, I do the procedure, orbicularis hitching maneuver, and test it again. And if it's still 10, you're going to have to shorten it horizontally. And if it's less than 5, you go ahead and close it. But if it's in between, then I'll shift that margin toward the nose and then test it again. If it's still more than 5, you're going to have to do something. But if it's less than 5, you can close it. So how often do I end up having to do something at the canthus? Not very often. We'll get to those in a second. But from the volume perspective, you visit the tide, you visit the beach at high tide. It's pretty. It's not so pretty at low tide, of course. But that stuff that's offensive out there, that trash and rocks and seaweed, it was there all along. Of course, we just didn't see it. So the history of eyelid surgery has been to clean that stuff up, do heavy lifting, and we really don't need to do it. We just need to bring the tide back. And that's, of course, just exactly what fat grafting does for us. So it's powerful. Of course, our tide goes out once over a lifetime, sometimes pretty early in that life, uncovering our fat bags and our shoals and reefs and rocks and orbital rim and malar peak and all of that, and you can fix it all by bringing the tide back instead of doing heavy orthopedic surgery. And I've done many types of tear trough grafts in my career, and I used to take a block of dermal fat and fascia from behind the ear. That works great. You sew that in. You take a graft from the abdomen. You take a silicone implant. They all work. They take an hour to do or more, but I can do this with a needle in minutes, and it's better. It's more controllable, et cetera. Here are some examples of that. This is a patient done with a graft from behind her ear, no incision. Those are sewn in transcons, but there's no skin incision, no lower lid incision. And those work quite well, but it was complex and it was a lot of work, and it's far more facile to do that with fat grafting. Here's an example of a dermal fat graft, injectable fat in the upper lid, but a dermal fat graft sewn in below, and somebody had a scar someplace, and they work fine. Here's a woman not having a regular facelift, just a mid-facelift, so there's no facelift scar, so we're going to use an implant, silicone. I used Bob Flower's implant, which I modified. I switched them left to right and cut them a little bit, and they work fine. But it's far simpler to learn how to do structural fat grafting. Of course, the lower lid might be the most challenging area. And this is the first case I did in '99 with a microneedle in the fat grafting in the lower lid, and it worked out all right. So for me, lower blepharoplasty is going to be medial and lateral augmentation of the suborbital zone by a blunt needle, invariably. Conservative laser resurfacing, again, at 95% at low, very low setting. And then this operation in only 20% of them. Finally, I remove, I do that tarsopexy in 2%, where I feel I can't get things as tight to the globe as they need to be. And then finally, in about 5%, I actually need to remove some fat because there's just too much tide to bring in. Silly, so you remove some fat. So it's an orbitoplasty for me, so let's look at that. 60-year-old secondary patient. She's got lax lids, lots of scleral show, terrible skin condition in her face as well as her eyes. Negative vector, of course, according to Glenn, and then really a lot of lid distraction. Her snap test is much delayed. So she's got a really lax lid, and so what are we going to do for it? Well, number one, I'm going to test how much descent there's been to her muscle coat, and that's a dot there that I then pinch the skin and the muscle together and lift that as a direct vertical suspension with no tension whatever to see if that's the right amount. And when I determine that right amount, and that's a determination I make 3, 4, 5 times, then my incision line goes from the caruncle down to that, and much as you see. And once you do that, you don't adjust it at all, except to maybe take out some lateral dog ear, but I don't do an intraoperative adjustment of that ever. And so I test it again and make sure I like it. You can't pull up and be pulling on the mouth and everything when you do this, or of course you'll have problems. So this is a tension-free elevation of the muscle coat with the overlying skin. Now I'm marking the depth of the tear trough on the nasal side, and then marking the lower border of the topography of the face lid region. I'm going to graft from that blue line up to just above the orbital margin. And there I am. You can see the plunger barely moving. I'm not using my thumb, but the trick here is I'm moving back and forth in a rhythmic fashion, almost like liposuction, but that plunger is barely moving. So I'm fulfilling Roger's requirements about how little you do in any one pass, and Sydney, of course, the same. Here I'm measuring now my distraction. It's over 10 millimeters, so of course we're going to get some help from things. We excise the skin that we estimated preoperatively, and so of course that's rapid, and then poke a hole in the upper portion of that laterally, just below the skin margin, with a sharp scissors, and then the dissection is limited to 3 or 4 little snips of your sharp scissors staying right on the orbital margin. Don't get it immediately. You might get in the canthal tendon. You don't want to be over the orbit, but you want to be over in the orbit, but over it. And then you put a stitch at the level of the canthus through the lateral periosteum, and then you engage your exposed lower muscle. And look how much muscle there is in this patient with her sort of crippled eyelids, and it's a lot. And then you need to go back in, 5, 6 millimeters away so it doesn't pull through the muscle. That's a 5-0 nylon monofilament. And then you tie it. So the first hook brings opening the muscle back up over the lateral canthal region. The second assistant holds that muscle so I don't catch it in my knot. And you just tie it, and up it comes. And then invariably you need to free a millimeter or two over a distance of 8 or 9 millimeters because the skin margin gets pulled in a little bit. That's just 2 or 3 snips. And now you're ready to test it and see what you've accomplished. And if we're lucky, we've got adequate adherence to the globe. Remember, it's more than 10. Yeah, it's 2 or 3 now, so it's fine. I don't have to do anything more. But if it's still relaxed, I would simply move that lid margin toward the nose with a couple of sutures. So here she is. It's an early result. She's out of town, out of country. But you see and you see how I'll show you some other results in motion like that. I think it's a better way to judge our results. So here's the June 16th. Morris Hartstein's an oculoplastic surgeon in Tel Aviv, and he wrote it with me. And average follow-up 15 months, age range 55 average, 86% females. A third of them had surgery before. I added fat in all of them. I removed fat in 6 lids. Skin resection averaged 8 up to 20. Tarsopexy in only 2, 1 lid each in 2 patients, no malpositions and no reoperation. So I think this is a straightforward way to do lower lid surgery. I recommend the article to you to take a look at and see what you think of it. So this is orbicularis hitch with laser and fat grafting, but no fat removal. Not a drop of fat's been removed from a lower lid. It's simply been added to, and the same here. Nothing removed in any of these patients, and it's unusual. Notice I filled in her labial manifold too, and so again, no fat removed, fat added. The most important thing I do around the eye is add fat. Again, no fat removed from these lower lids. Simply, all of these had that procedure. So let's look at just fat as a modality alone in the suborbital zone. What does it do to architecture, lid posture? Well, fat grafting to the suborbital fills the suborbital hollow, period. It just does. You do it right, it fills it. It's filled. It usually camouflages the fat bags without the need to reduce them. It's only 5%. Usually camouflages bad fat graft deformities too without having to cut them out. I'll show you a case. May improve minor lid level malpositions. May. As long as there's no lid fixation, often improves suborbital dyschromia. And Sidney goes into this at length and really has some very impressive results where he's worked on the lid for color alone. So this is a patient after blepharoplasty, a year after blepharoplasty. Notice again the improvements to the upper eyelid too. The medial brow comes down, we fill the lid, and the lower lid filling occurs. It didn't happen at her first procedure. And older patient with hollowness, but I'm making the point here that even as a young woman, a young vital woman, she still had a lot of suborbital emptiness, which she no longer has, and that's true of many of us, most of us. I developed mine quite early in life. There's a patient with, again, sclerotia, and we've hyperpositioned her, the placement of that one single suture around the orbital margin, 2 or 3 extra millimeters. But again, reduce her white triangle, and we get that filling that we need. There's that patient that had the bad upper lids, same thing with the lower lids. And again, none of these have had tarsal surgery or canthal surgery. That suture's been hyperpositioned. And there's a trick to make it symmetrical. There's that patient with the bad stare, but she's got what looks like excess muscle. Well, I don't believe in removing orbicularis muscle. I think you camouflage that with fat and not disturb the muscle and the blink reflex. First case I did in '99, and it turned out all right. And just some others, lower lid. And again, you see it better. In a case like this, relatively subtle, you're going to see a lot more from of course, the lateral view or the 3/4 view. Here's an older patient, no eyelid surgery, but look, the improvement the upper and lower lids, and she's now 73 on the right, and she's late 20s there, when she was a beauty queen in her home country. So no substitute for that I know, and I don't think you can achieve quite that level of repair with fillers, but I welcome opinions from others on that. Again, it can hide apparent fat bags. Here's no blepharoplasty of any kind. I occasionally lift brows more than I do for special circumstances, such as this patient, but I don't do it often. Again, we hide fat bags rather than removing the fat without the need to enter the lid. She's had no lid surgery. Same thing here, no blepharoplasty. And again, notice that I haven't filled her face as much as some might because she's had that as her facial personality all of her life. In 5%, yeah, 5-6%, I'm going to have to remove some, but I remove only a little. Most of what this woman received was added fat. She's got an uncorrected ptosis. She still hasn't gone to get that repaired. I've referred her, but I don't do that surgery. There's a bad fat grafting by a board-certified plastic surgeon, and we can camouflage it if you work superficially and slowly and take care. And then while you're at it, fill her cheek and do some other things. No, the lips weren't done by me. Here's a woman after a blepharoplasty, and we're not going to repeat the blepharoplasty, but by adding fat, we have actually supported that lower lid and improved her lateral bowing significantly and changed her white temporal triangle into the narrow triangle she had as a young woman. So, and of course, she did have a facelift, but she didn't have anything done to her eyelids. Just that original procedure. Then that woman I showed you, one of the first ones, and we just support that lower lid a little bit more, and I'll just show you her. She wears too much makeup, unfortunately, as she's gotten older, but here she is at the age 60. That's 9 years later, and just look how well fat holds up, and I think all of you out there are using fat regularly expect it to last well beyond 9 years. I do, surely. So again, supporting the lower lid can give us a, but it's a may. It's nothing you can count on. This is the only patient in here with light skin that I haven't lasered because she'd already had laser. So this is just fat grafting without laser. And every other case I've done, I like that. I don't have the sophisticated lasers that Jason has, but I like the laser, and I do it very lightly on virtually everybody. And so this is the combined effect of fat grafting the lower lids plus ablative laser at a very low energy one time, and I don't like to see it repeated in that patient's lifetime. And Sydney gives a very good talk about this as superficial fat grafting, and it's the last thing you should try as a fat grafter. It's the hardest thing to do around the eyelid is try to put fat in between the orbicularis and the skin. You have to be really, really good before you try that. That's your last effort. And then, so all of these show some improvement, and how much is laser, how much I can't say. But I learned early on from this patient particularly, it's when she was going to have 2 fat grafts. She came back after the one. She'd had some things done where she lived a long distance away, and she comes back after the one. She looks better, and I get these pictures. And of course, after the second one, I don't have a follow-up because they don't come back if they're happy. So it's much truer to life. You get a lot more information from a video of a patient after this surgery, and you get a lot more indication of what you've been able to do for your patient in a video format than you do in a side-by-side before and after. So just focus on these lower lids a minute on a couple of these as I just finish up with these lower lid situations. See how much more apparent the improvements are, and so it's a good way to and then also particularly in smiling, and yeah, that's not so wonderful. And you know, I actually went back and did a little something in the hair, which I do in 5% of the time, to lift that a little bit more there. It's very quick and easy to do, but you won't do it if you don't see it. And a good way to see it's in video or real life. So again, things just, the apparent improvements are so much more there. It's a very demanding modality though, because things look pretty good on a still snap. You can see some things you'd like to fix in the video, but you see significant improvement. Trying to frown, I'm showing that what happens when you cut the depressor angulioris on patients, and same thing here. You see improvement, but you don't see the improvement the way you do in this truer to life depiction. Now you know why she was a happy facelift eyelid patient, and before you might have wondered why, just looking at it on a side-by-side still picture. No eyelid surgery in this patient. This is just fat grafting and laser alone. And again, you see the apparent differences, and you can quibble with that and say, well, you should have taken a little something out of that left lid. And I said, yeah, I might. But you can make that argument. I tend not to want to see about a 5-millimeter excision of skin before I do it, but I make exceptions to that. And again, nothing removed from this woman's lower lids. Yeah, I'm all right with time, Jeff, so I think this is it. And again, you learn a lot on the smile, and you even learn something on the frown and the frowning positions when you get the motion. It's more information, more data points. So I thank you.
Okay. Thanks, Bill. Our last speaker for the session is going to be Tim Martin, who's going to talk to us a bit about facelifting and bringing fat in to augment and complement its results. Tim?
Thank you. Let's see, I have nothing to disclose, level 5 evidence, and I'll leave a reference for anyone interested in the lower left-hand corner of the slide. So here's the mystery we have to unravel. Here's a woman at age 22 and age 61, and something's happened in that intervening interval. What is that? How do we fix that? The components of this include descent of the lid-cheek junction, cheek pad ptosis, nasolabial fold formation, malar flattening, jaltosis, marionette line formation, cervical band, forehead ptosis. Which facelift technique should we use to address those problems? Should we do a skin-only facelift? Should we do a SMAS facelift, a subperiosteal facelift, or some other kind of facelift? I favor the SMASs. I know many of you do. Why is that? Well, someone's probably saying, isn't it easier and faster just to lift the skin? And although lifting the skin only may be easier and faster, I can tell you it will result in inferior outcomes. A skin-only facelift failed this patient. If you look carefully, she's got a preauricular scar there. She's actually had a facelift, and yet all those problems of aging that we just went through are still present. So why did lifting the skin only fail, and why is SMAS better? Well, skin is intended to serve a covering function, not a structural or supporting one. Skin was meant to stretch and move as we smile and express ourselves and yawn, not to hold anything up. Skin tension, excuse me, actually flattens contour rather than restoring it. If you imagine me stretching a rubber sheet over my face, it would actually press down on my nose and my cheeks and my chin. Skin tension results in pore scars, hairline displacement, tragal distortion, earlobe malposition. Name a secondary facelift irregularity, and I can probably trace it back to too much skin tension. And skin is not capable of providing sustained support of ptotic deep layer tissue. You may be able to make the patient look good on the operating room table, but over time, being a non-structural layer, that effect will be lost. SMAS, however, provides better repositioning of ptotic facial tissue. It's a fibrous aponeurotic layer. SMAS repositioning results in a soft, natural appearance by getting tension off the skin. We don't corrupt the skin's covering function. It gives us better scars. We avoid traction deformity on the ear. We triple or quadruple the lifespan of the improvement, and it gives us a means of repeating a facelift procedure without creating a tight, unnatural surgical look. More fundamentally, the SMAS is just more closely associated with the tissue layers descending with age. It's not really that the skin is dropping or the periosteum that's falling. It's everything in between the skin and periosteum that is descending, and the SMAS is the layer most closely associated with that tissue. Suspension sutures are not capable of producing any kind of uniform or sustained improvement, and fillers can't overcome tissue ptosis. Skin redundancy, skin surface treatments don't address deep layer problems. So our contemporary strategy is we create contour by modifying the SMAS and deep layers of the face, not by tightening the skin. We treat skin as a covering layer and only remove skin that's truly redundant. And here she is after a skin facelift on the left and after a SMAS facelift on the right, and most of those problems have been improved. So at 22, 61, and 63. The lecture was entitled High SMAS. What is that? Well, our traditional deep plane and low SMAS procedures only targeted the lower cheek and jowl, this area shown by the green circle, but didn't produce any improvement in the midface and infraorbital region. That's why we developed mid-facelifts. The question is, can this traditional low SMAS procedure be redesigned to overcome this limitation? My answer to that is yes, and that's the high SMAS I'm going to show you now. So to explain the high SMAS, let me explain what I mean by low SMAS. In a low SMAS operation, the superior margin of the flap is planned well below the zygomatic arch, mostly in an attempt to protect the frontal branch. And when that flap is elevated and sutured, you're achieving most of your lift on the lower cheek and posterior jawline. You're not lifting the anterior face and midface. It's just the biogeometry of that flap. In the high SMAS, we plan the superior margin of the flap higher along the zygomatic arch, and when that flap is raised and sutured, we expand the effect of the flap to include the whole face, not part of the face. The midface is included. We're getting a midface lift for free if we just plan our flap in a more strategic way. So just to show them side by side to hammer home the concept, in the low SMAS, the flap is performed below the zygomatic arch, the high SMAS along the arch. In the low SMAS, we're only lifting the lower cheek and posterior jawline. In the high SMAS, we're lifting the whole hemiface. The low SMAS, we miss the midface. The high SMAS, we capture the midface. So the advantages of that strategy, it's a single flap with a combined effect on the midface, cheek, and jowl. Ptotic tissue is repositioned in a balanced, harmonious fashion. No separate midface lift is required. Tissue redundancy is redistributed in the upper cheek, where it often does the most aesthetic good. The SMAS layer is not disrupted and can be used again at a future date, unlike some plication and SMASectomy procedures. The other part of the lecture title was lamellar high SMAS. What is that? It means that the skin and SMAS are dissected as two separate layers, or lamella, and that allows us to advance the SMAS and skin along independent vectors. The SMAS wants to go parallel to the long axis of the zygomaticus major. The skin wants to flow more posteriorly, perpendicular to the nasolabial fold. And that gives us the concept of a bidirectional facelift, where we're treating the skin and SMAS as separate layers, different than a deep planar composite dissection, where the skin and SMAS are left attached to each other and have to move in the same direction and the same amount. That's a unidirectional tissue shift and lacks some versatility. So the advantages of a lamellar dissection is it allows skin and SMAS to be advanced along independent vectors. It allows maximum elevation of deep tissue without overshifting skin. Skin tension can be set low. We minimize wrinkle shift from the neck up onto the face, and I feel we achieve an overall more natural appearance. So let's talk about technique, and the first question I'm usually asked is, how far is the skin undermined? And it's a good question, because skin undermining is not arbitrary. It has to be performed in a thoughtful way. There are some key areas that need to be released and some specific ligaments that need to be preserved. Here's a patient on the table. This would be my anterior extent of skin undermining, and my inferior, my typical face and neck lift, all that skin would be subcutaneously undermined. Someone's saying, well, why all those squiggly lines? Why are you doing it that way? Why not undermine further on to the cheek? I was taught as a resident, the harder the facelift, the farther out on the cheek you go. Isn't it better to go all the way to the nasolabial fold? And the answer is no, it's not, because when you do that, you divide the platysmic cutaneous ligaments, shown here by those white dots. The platysmic cutaneous ligaments are the means by which the perioral tissue is going to be lifted when you raise the SMAS. If you divide those ligaments, you're actually compromising the effect of your SMAS and the improvement you get in the lateral perioral region. So you divide those, support of that lateral perioral skin is lost, and the so-called lateral sweep deformity occurs, where you have unsupported skin in that area. Someone's saying, well, why undermine all the way out onto the jawline? We do that to release the mandibular ligaments. That helps us blend the fat of the chin and the jawline to get that nice line. So if we don't release those, generally it's hard to get complete correction of the jowl. Why undermine up onto the chin like this? And that's because we can make our incision posterior to the crease and undermine retrograde through the submental retaining ligaments. And then when all our other face and neck lift maneuvers are completed, we can blend the fat of the chin and the submental region to get that perfect straight line. The next question I'm usually asked is, well, how far should the SMAS be undermined? Also a good question. It's not arbitrary. There's some specific ligaments that need to be released. And a clinical effect must be obtained. It's not enough just to raise the corner of the SMAS and impress the nurses in the operating room. You actually have to raise it enough that it does the patient some good. So the key to understanding that is that the upper cheek and midface are restrained by the zygomatic ligaments shown here as these little dots near the origin of the zygomaticus major muscle. And the lower cheek and jowl are restrained by the protomesenteric ligaments represented here by these little squares along the anterior border of the parotid gland. If those ligaments aren't released, you're not going to achieve a proper SMAS effect. So here's the markings. We mark a line from the level of the infraorbital rim to a point about 1 centimeter anterior to the superior margin of the tragus, and we carry that line down inferiorly to curving backwards to the anterior border of the sternocleidomastoid 2 to 3 millimeters below the mandibular margin. You can see that that plan puts the superior margin of our flap over the zygomatic arch, the so-called high SMAS position. Someone's saying, is this safe? What about the frontal branch? This has been the traditional resistance to the high SMAS, but if we look at our traditional landmark of the inferior tragus to a point, 1.5 centimeters above the brow, you can see that the nerve is only in our field of dissection. The first centimeter or two, we're raising the flap. At that point, it's actually buried in the parotid gland, densely adherent to arch periosteum, some 10 millimeters deep. It would be very difficult to injure that nerve. So as soon as you've got that first centimeter of flap up, you're actually beyond the nerve. The frontal branch is safe now that we understand this anatomy. So to raise the flap, we grasp on each side of that superior line with Alice forceps and lift the SMAS up away from the deeper tissue and then just nibble into the tissue that's being lifted. We're not cutting all the way down to the arch, we're just cutting the SMAS layer that's being lifted. And then we reapply those clamps and cut a little further, and then we reapply the clamps and cut a little further. And now we've defined the superior margin of our flap. We do the same thing with the posterior margin, and now we've defined our superior and posterior flap margins. This blue area is the area that we agreed earlier that needs to be released to get a proper SMAS effect. So we're going to apply those 2 Alice clamps to this upper lateral corner, and using a Metzenbaum scissor or needle tip cautery, we're going to come on the back side of that SMAS flap. You can see we're already well past the frontal branch at this point. Here I've gone a little farther. It's typical to see some sub-SMAS fat, but in a very thin elderly patient, you may actually be looking at some parotid capsule there. Here you're not looking under the skin. Here I've raised the SMAS flap. It's not always necessary to raise it quite this extensively, but there's some great anatomy for you to see. Here is our SMAS layer. You can see the platysma coming up from below. You can see how it gets thinner as we get up into the face. This shiny stuff is the protomesenteric fascia. That's important because all the nerves are deep to that. So as long as you come out on top of that shiny stuff, you're safe. That is the origin of the zygomaticus major, an important landmark in SMAS surgery, something that you need to generally peek at the top centimeter or so of it. There's the origin of the zyg major right there, and here's the malar fat pad up in the flap there. Here's a little nerve branch. Here's a little nerve branch. You can see this nerve branch under this shiny stuff. Here's the parotid gland, this pink brown, and this darker ruby red area is the masseter. We're coming off the parotid in the masseter, and that's typically where you see those nerves exiting. Those blue dots represent the zygomatic ligaments that were restraining the upper cheek and midface. And these black dots represent the protomesenteric ligaments that were restraining the lower cheek and jowl. If I only would have lifted the SMAS flap this far, I wouldn't have done the patient much good because those ligaments would still be present and the SMAS layer wouldn't lift the lower face. And while anatomy is an important signpost, as clinicians, we just really want the effect. So the endpoint of SMAS dissection is not necessarily seeing the anatomy I showed you, it's getting the clinical effect, and that's achieved by the traction test. So the SMAS is mobilized until elevation of the flap gives you the changes you want on the face. So I'll show you a little video of this. I will have raised the skin, I will have raised the SMAS. I'll put 2 Alice clamps on the superior flap margin and we can watch what happens to the face. Okay, so skin dissected, SMAS dissected, and now I'm going to pull on the superior margin of the SMAS. We can see the jawline moving, we can see the corner of the mouth moving and the teeth showing. But look what's happening up here. Look how the lid-cheek junction is moving up. Look at the skin being pushed into the orbit. Look at the cheek going up. We're lifting the whole hemiface, including the midface, not just the jawline and lower cheek. Just a little more. Look at the movement. Look how much skin we're pushing into the lower eyelid. The whole face is going up. That's the high SMAS effect. We're getting a mid-face lift for free. Once we mobilize the flap, we have to suspend it. And if properly mobilized and released, the SMAS can be suspended under minimal tension. The goal in all facial surgery is to reposition ptotic tissue, not to tighten the face. If you examine the young face, it's not tight. Tightening is an aberration we create. Over-tightening any layer of the face, including the SMAS, will result in unnatural appearances and secondary irregularities. The SMAS should be advanced along a vector parallel to the long axis of the zygomaticus major. That's the muscle we smile with, and elevating along that vector will put a faint smile in the patient's face. There should be no posterior pull on the SMAS. When we do that, we're pulling on the risorius. We're putting a clown mouth onto the patient's face by pulling the mouth sideways. So posterior traction will result in perioral distortion and unnatural appearances. So there's 3 broad strategies how to manage this superior flap margin. When we have an incision in the temporal scalp, as I do here, typically in a young patient, that's sort of the first scenario. We can just raise the flap up, and then we can anchor it down to this temporalis muscle fascia, a very convenient place to anchor to. I just use 3/0 PGA suture. Each of those triangles represents a suture point. You can see we don't need to suture out over the zygoma. That mid-face tissue is just going to ride up with our flap as it has here. You can see here's the original position of our SMAS where we harvested it from, and you can see that this overlapping of the SMAS creates an increase in interzygomatic distance, a more oval-shaped face, very valuable in Caucasian faces, female faces. The second situation would be when the incision is along the hairline. This happens to be a man, so it's more rectangular. In a woman, this would be a little more rounded. In that situation, we're going to put a retractor on that little sideburn area and incise the galea, do a little galeotomy to expose that same temporal fascia that we just sutured to. So in other words, in the first version, we divided the mesotemporalis to unite the subgaleal and subcutaneous planes. And this is the same layer right there. And in this case, we can preserve the superficial temporal artery, whereas in the first scenario, we divided it. And the galeotomy is roughly in the same place. But what this allows us in this case to preserve that superficial temporal artery, and we can see the frontal branch is conveniently safe. And what this allows us to do is grab the corner of our flap and suture it to that same deep temporal fascia, getting that same overlapping. Each of those triangles is a suture. Then the little sideburn flap is flipped back down where it belongs and just tacked in with a few absorbable stitches. Here's the original position of our SMAS. There's the overlapping that's going to give us a more oval-shaped face and increased interzygomatic distance. The third scenario is the patient with the broad face, the Slavic face, the Asian face, patients who don't want their face to become broader, the patient with the small mandible where making the interzygomatic distance makes their mandible look more mousy and small. Circumstances, a male face where zygomatic widening is not wanted. What do we do in those cases? That's the third scenario. We lift the SMAS up, we mark the excess, we trim that excess off. Here I'm trimming it, and then we suture it edge to edge without any overlapping. So here's the first stitch going in at that white triangle. When I'm all done, there'll be sutures, putting that SMAS back edge to edge. Here, we're getting the same lift, but we're not getting that overlapping and an increase in interzygomatic distance. So we can't have a cookie cutter operation. We have to tailor it to the patient's appearance. Regardless of what we do to the superior margin of the SMAS, there's going to be a little posterior excess, and that's trimmed off just to match the cut edge underneath it. So we're not pulling it all on this part. And that we're going to leave that tongue of tissue attached to the cervical platysma, transpose it to the mastoid, and use it as a post-auricular transposition flap. What's that? That's this scenario where this little piece of tissue is going to be left attached to the cervical platysma, transposed to the mastoid, and then combined with our anterior platysmoplasty, we can advance that tissue onto the mastoid, anchor it with a suture to get a mastoid to mastoid sling of autologous tissue. So here it is on the patient. We've transposed that tongue of tissue to the mastoid. It's usually a little too long, so we trim it off and anchor it. And then we close over the parotid. We don't want the patient to get gustatory sweating or Fry's syndrome, so just some housekeeping. We put that layer back together over the parotid under no tension. Each of those white triangles is a place where we put a suture. Here's a patient in the operating room. We've only suspended the SMAS on the right side. The skin has not been trimmed or suspended. It's just laying on her face. She's under anesthesia, but it looks like she's smiling at us on the right side. That's the SMAS effect. We look at the corner of her mouth and compare it to the other side. It's been raised. Look at her cheek and compare it. Look how flat this cheek is. Look how round and projected this cheek is. And look at the lid cheek junction. Look how low this lid cheek junction is. Look at how it's been raised. And look at the several millimeters of skin have been pushed into the lower eyelid. That's the high SMAS effect. We're getting both a lift of the jawline and the midface. Here's a patient, again under deep sedation. It looks like she's smiling at us. The SMAS has been suspended on both sides. The skin is laying on her face, hasn't been trimmed or suspended. It looks like she's smiling at us. Look at how much tissue, how her lid cheek junctions have been raised, her cheek has been raised. So a few case examples, a 65-year-old who's had prior blepharoplasty. Here's our plan, high SMAS facelift and related procedures. We've achieved a soft, natural appearance. Her face has gone from a bottom-heavy sort of rectangular shape to a more inverted oval shape. She has a very natural appearance when she smiles. The three-quarter view shows a nice repositioning of her midface. The posture of her mouth is improved. Her jawline is improved. We can see a better transition from the lower eyelid to the cheek. Well-concealed scar, good neck when she looks down. A 49-year-old, prior blepharoplasty and laser resurfacing, high SMAS facelift and related procedures. Again, a soft, natural look. We've taken that square, bottom-heavy face, made it more into an inverted oval. She looks very natural when she smiles. We can see the improved transition from the lower eyelid to the cheek, improved posture of the mouth, improved jawline, neckline, well-concealed scars, good neckline when she looks down. A 39-year-old, prior submental liposuction, high SMAS facelift-related procedures, a soft, although less dramatic, improvement. She looks natural when she smiles, improved transition from the lower eyelid to the cheek, improved posture of the mouth, improved jawline, improved neckline, good neck when she looks down. An Asian face, 56 years old, high SMAS facelift and related procedures, a nice reshaping of the face, a more oval, feminine shape, natural when she smiles, improved lid cheek junction, jawline, neckline, good scar even though she's of Asian ancestry. Hispanic woman, no prior surgery, high SMAS facelift related procedures, a soft natural improvement, improved transition from the lower eyelid to the cheek, improved neckline, jawline, good scar. And I think the final case, a male, high SMAS facelift related procedures, a soft natural improvement, looks natural when he smiles, improved transition from the lower eyelid to the cheek, improved posture of the mouth, jawline, neckline, good scars. So can this lifting reverse all aspects of aging? Have we really fixed everything? The skin lift didn't fix everything. The SMAS lift produced an improvement, but what's the difference between those two photos? Is facial fullness. Look how full her upper eyelids are. Look how full her cheek and lower lid is. Look how full her lower lip is. Look how broad her chin is and how plushly padded her jawline is. And here she has a gaunt, hard appearance despite our best efforts with our SMAS technique. So lifting doesn't treat atrophy. You can't lift an empty space. How do we treat atrophy? We fill it. We fat graft. And these kind of facelifts were unachievable by lifting alone in my practice. I had to add fat grafting to go from that before photo to that after photo. So this fat grafting is the missing link in facial rejuvenation. It's why surgeons like showing 2-week and 2-month follow-ups at medical meetings, because the patients are swollen and they look great when they're swollen. It's why a mid-facelift always looks good in a 3-month or 6-month follow-up photo, but not so good at a year. Fat grafting represents the most important new addition to facelift surgery since the introduction of the SMAS technique. And despite what we thought about lifting, it's not going to do the whole job. Why facelift and fat grafting? Why not just the facelift? The answer to that is in the multifactorial origin of facial aging. I like to say to patients and to residents, patients age in 3 categories. The surface of their skin ages, that we address with skin care and resurfacing. Things fall, droop, become loose and redundant. That's where our lifts come in. And the face is undergoing a process of hollowing, medically known as atrophy. And that's where fat grafting comes in. So the advantages of fat grafting is it gives us a more comprehensive treatment of the aging change. We're treating all 3 categories, not just 1 or 2. It's a volumetric rejuvenation. We're moving from being 2-dimensional tailors to 3-dimensional sculptors. It's autologous, it's long-lasting, and there's this stem cell rejuvenative effect. This may be the first time plastic surgeons are actually truly rejuvenating and not just creating a cosmetic improvement. There are disadvantages. There's a learning curve associated with fat grafting. It'll increase your time in the OR. The patients will have more swelling, a longer recovery. There's some uncertainty of graft take, and you're going to have to overcome certain patient misconceptions about it making their face look fat or the fat moving and so on. But in summary, my treatment philosophy is combine facelift and fat grafting works synergistically to treat 2 different problems, and the 2 procedures performed together produce a better outcome than either one performed alone. So when do we do this? Do we do it at the beginning or the end of the procedure? I like to do the fat grafting at the beginning. Why is that? I like to harvest the fat in the morning before the face is prepped and the patient draped. The patient's in a deeper plane of anesthesia in the morning. That's helpful in the fat graft. The marks and landmarks that you made are easier to see. If you wait till the end of a 6-hour facelift, all the little purple lines you marked with a patient sitting up will be wiped off the face. I like putting the fat in before the face is swollen or the tissue planes are open. I like the fat to not sit on the back table for 5 hours. But the real reason I like to do it in the morning is I'm more technically and artistically energetic, and I will do a good job. If I wait till the end of a 5 or 6 hour facelift to inject the fat, I'll be tired, I'll make bolus injections, and the result will be compromised. So we typically harvest from the lateral torso. This is a more forgiving area. It's easier to get more fat from than the abdomen. So we turn the patient into this semilateral decubitus position, a quick povidone iodine prep, and limited drape. In this position, you can actually get fat off the inner knee, inner thigh, buttock, hip, outer thigh, waist. If you get 10 cc's here, 10 here, 10 here, 10 here, 10 here, 10 here, you've got 60 cc's from that side, and you flip the patient over, you get another 60 cc's. The area is injected with a 0.1% lidocaine 1 to 1 million epinephrine solution. I inject about 1 cc's for every 3 cc of anticipated fat removal. You don't want to overwet the harvest site. And then I harvest with a 2.1 to 2.4 millimeter cannula on a 10 cc syringe using light vacuum, 1-layer closure, 6/0 nylon. We put a tegaderm over that, and then flip the patient over and harvest the other side. We then centrifuge, and this was discussed this morning. Why do that? Although it seems that the science is unclear that this is superior, we need uniform material to inject, and the fat as you harvest it is not uniform. One syringe could be 9 cc's of fat and 1 cc of blood, and the next syringe could be 60/40 or 70/30, and we don't want to just transfer that to the right and left cheek. We want the equal number of fat cells per unit volume. So centrifuging homogenizes the fat and gives us that equal volume. We want to discard cells that were injured during the harvest. We don't want to inject ruptured, dead fat cells and oil into the face. We want to concentrate high-density adipocytes. Not all fat is the same. The bottom 2 cc's in that 10 cc syringe are high-density adipocytes. They have a higher stem cell activity, and we want to retain any growth factors or cellular messengers, PRP-like things. If you just wash the fat in a tea strainer or put it on Telfa, you're throwing away a lot of good chemical stuff and biologically active stuff, in my opinion. So we centrifuge at 3 minutes at 1,000 RPM. And when you're done centrifuging it, there'll be oil on the top, fat in the middle, and the blood and lidocaine in the bottom. You pour that oil off the top. Sorry, the bottom 2 cc's are the stem cell-rich, high-density adipocytes, the adipose-derived regenerative cells. The oil and water are drained. The first 2 cc's on the bottom of the high-density fat is segregated by my team for use in critical areas like the eyes and lips. If you over-harvest, you can do the entire case with that stem cell-rich fat. In other words, you only use the bottom 2 cc's and you either discard or re-inject the upper fat back into the patient's body. Then you've got to transfer it to 1 cc syringes. You can't properly inject this fat with a 5 cc or even a 3 cc syringe. You need to get it into 1 cc syringes so you can administer it in very small aliquots. According to Coleman's principles, that means we're going to use blunt injection cannula, not sharp hypodermic needles. They range in size from 0.7 to 1.2 millimeters. We're injecting small amounts per pass, less than 0.05 cc's per pass. In other words, we're going to move that cannula back and forth 40 times or so to empty the 1 cc syringe, as Bill Little showed us. We're going to inject in multiple passes. We're multiple planes appropriate for the area treated, and we're going to feather into adjacent areas rather than make bolus injections. So here's what the tools look like. They fit on a 1 cc syringe. So you've harvested this fat, you've processed it in a centrifuge, you've loaded it into 1 cc syringes. What can you do with it? How can it make your facelift better? You can inject it into the cheeks. You can use it to efface the nasolabial folds. You can use it in the lips. I like how fat looks in the lips. It produces a soft filling of the lips. A filler sometimes creates a more stylized lip appearance. The geniomandibular groove, this transition from the cheek to the chin. The entire jawline. Often as patients age, the mandible recedes and the face becomes mousier, more frail looking. People who are photogenic, athletic, healthy have a strong mandibular contour. The eye likes it, the camera likes it. And you're often doing that posterior jawline in conjunction with the geniomandibular groove to get that line. The atrophic mouth. This is not just a wrinkled mouth, and if you lasered those wrinkles away, it would still look elderly and unkissable. This is a wrinkled and deflated mouth. It's an atrophic mouth. And to get to that after photo, you have to not only resurface, you have to fill. Buccal atrophy or deformities caused by buccal fat excision. This was an almost impossible problem to treat. Before fat grafting, you can see she's nicely filled in here. The weak chin. This is not a chin implant. This is a patient who had a chin implant put in by someone else. It was removed. I told her she needed another one. She said she didn't want another one. Do your best with fat grafting, and I was stunned when I got this result. The atrophic or feeble chin, this chin on the left is not really small, it's just deflated with age, and just filling it back up has created a more athletic, sensual, youthful appearance. And then the small mandible, these people with big zygomatic profiles and sort of mousy mandibles, putting fat along the jawline can create a better balance and a more photogenic face. The long face, where you put fat into the cheeks, into the preauricular area, into the GMG jawline. Basically, we're broadening the face to balance its length and create a more proportionate appearance. Temporal hollowing. No matter what you do and how skillful your blepharoplasties are, if there's a big hollow in the temple, that patient isn't going to look their best. And this is a hallmark of being in your 40s, this temporal hollowing. Very effectively treated with fat, as I think Bill showed too. The tear trough, the hollow orbit, what patients call nursing home eyes. Bill showed a lot of these cases. And the proptotic ocular globe, what we call a negative vector eye, what patients call frog eyes. This woman didn't have a craniofrontal facial advancement. We just buried that negative vector proptotic eye in fat and made her into a neutral vector eye. The atrophic cheek. 25 years ago when I started my practice, I saw this as a bag that needed to be removed. But this is really a pseudo-herniation of fat. It's not that this bag got bigger, it's that this woman's cheek melted away with age. And all I've done in this after photo is restored her cheek with fat grafting. No blepharoplasty was performed. In other words, what I did is filled her cheek up with fat to this point. If I would have done a blepharoplasty, this would be where her lid cheek junction is, but look where it is in the after photo. It's higher. And that's synonymous with youth and vitality. And some of you may have noticed that I also did her upper eyelid it's been filled. The over-resected upper eyelid, what patients call owl eyes. And the secondary facelift patient who has basically all these problems rolled into one. She's got temporal hollowing, she's got a hollow upper orbit, a tear trough hollow lower orbit, she's got a bony cheek, hollow buccal recess, a nasolabial crease, a drool line, a geniomandibular groove, and a mousy posterior jawline. And her lips and her radix, all those areas have been fat grafted. There's no way to get from that before photo to that after photo without adding volume. So how's the fat injected? Where are the incisions made? How much should be injected? This has been talked about by Bill, but basically you can make the incisions anywhere you want because you're just breaking the skin with a 20-gauge needle or an 11-blade. As far as how much fat should be injected, you can determine this preoperatively. Basically, you rate the defect in each area as small, medium, or large, and then you need some empirical information published by Bill or Sid or me. We publish a range of fat that is needed for each area. If it's a small deficiency, you go to the low end of that range. If it's a big deficiency, you go to the high range, and of course, you can go in the middle. And again, those numbers are in the reference there. But as far as how that fat is injected for the geniomandibular groove, I would inject something like this. Injecting from 2 sites rather than 1 gives you a smoother administration of fat. So it's a small to medium-sized cannula. You're injecting in this place from the periosteum right up to the skin. It takes 1 to 3 cc's per side, depending on how big the problem is. And this is a great beginner's area if you've never injected fat before. The cheek we would do like this, a small to medium-sized cannula, periosteum to skin, 3 to 7 cc's per side, depending on the extent of the problem. And this is another good beginner's area. The chin we would do much like the GMG, small to medium-sized cannula, periosteum to skin, 1 to 3 cc's per side. And this is intermediate in difficulty. You don't want to exceed those volumes or the chin starts to get globular and too much vertical height. Nasolabial crease would be done in this manner, a small cannula usually, pre-periosteal to subcutaneous plane. You're injecting superficially if you're treating the nasolabial crease, but you're going to inject more deeply if you're treating age-associated maxillary recession. You're going to put the fat down on the piriform. Intermediate in difficulty, the key here is don't overfill. And as many of you know from use of filler, proper treatment of the nasolabial fold requires filling of the cheek above it. The upper lip we would do like this. Small cannula, we're just submucosal along the lip borders, 1 to 1.5 cc's per side. The lower lip, much the same, slightly higher volumes. This is intermediate in difficulty, and keep in mind, if you look at young patients, it's their lower lip that makes them look young, and there should be a golden relationship of 1 to 1.6. The lower lip should always be distinctly bigger than the upper lip. For the mandibular angle, we would do it like this, a larger 1.2 millimeter cannula, and here we're injecting down on bone below the masseter muscle. So we're putting the fat where a talar implant would go, 3 to 6 cc's per side, depending on the problem, intermediate in difficulty. And often you're doing this in conjunction with treating the geniomandibular groove. The temple, we would do like this, medium-sized cannula to avoid perforating the veins in that area, subcutaneous plane, 5 to 7 cc's or so per side, intermediate in difficulty. The upper orbit we would do like this, crossing over at that A-frame area. Small cannula, suborbicularis oculi, pre-periosteal plane, usually 2 to 3 cc's per side. And think of this as not injecting the lid, but lowering the supraorbital rim. You're on the bone, you're on the inferior margin of the supraorbital rim. This is more advanced in difficulty, but very rewarding. The tear trough would be injected like this, small cannula down on bone, 1 to 1.5 cc's per side, and it's generally better to come perpendicular to that problem rather than just approach it laterally. And this is more advanced. Practice somewhere else first. Infraorbital, we would do like this, 07 small cannula on the bone, 2 to 3 cc's per side, and irregularities are less likely when you inject perpendicular to the problem as shown. The beginner always tends to approach it this way, and this is the way you're going to end up with a banana fold or an irregularity. This is advanced. Practice some other areas first. Does it last? Someone's saying that's great, but it doesn't last. It's a graft of living tissue. It's analogous to other grafts we do. It neovascularizes much in the same way. Here's this woman almost 4 years later after her procedure. Her cheek and infraorbital area is distinctly fuller, her cheek distinctly fuller, her nasolabial fold distinctly more shallow, her stomal angle distinctly fuller, her lips distinctly fuller, her chin distinctly broader, her geniomandibular groove fuller, her jawline distinctly stronger. We can see fat is present 4 years later in every place I put it. But patients often confuse resolution of swelling with loss of graft. If you make a very timid injection of fat, the patient will swell and look good, and then you and your patient will be disappointed when that swelling goes away. Often patients just forget how hollow their faces were. It is aesthetically nuanced. Many times you've done a lot of good for the patient, and you just have to look for a while to notice what you've done. The reality is, just like everything we do, some patients will need some follow-up secondary treatment. Someone's probably saying, well, isn't it lumpy? Lumps are actually uncommon now that we have good instruments and know how to do this. Fat, unlike filler, integrates with facial tissues, and there's a natural smoothing effect because to get it to survive, we have to actually scatter it as small particles. And frankly, fat grafting is my secret weapon to get a smooth face like this. So let's just go through one patient example. She's 45, no prior surgery. Here's our plan. We put 3 cc's in each upper orbit, 6 cc's in each temple, 1 cc in each tear trough, 3 cc's in each infraorbital area, 5 in each cheek, 1 in each nasolabial fold, 1 in each stomal angle, 2 in each geniomandibular groove, in the lips, 3 cc's in the glabella, total of 50 cc's, and here she is 2 years and 4 months after. Here's the useful slide. You can see her before and after, and there's the plan for fat grafting. So here's your rough diamond on the left, and here's your perfect solitaire, and this is the vision you have to have for your patient in your mind's eye when you set out to do this procedure. 47-year-old, high SMAS facelift related procedures, fat in these areas. And here's how we got to that place. A few examples. I have to go through them quick. 62-year-old, high SMAS facelift, 70 cc's of injected fat. Look at the improvement in her temples, orbital area, cheeks, mouth, chin and jawline. Temples, orbits, cheeks, mouth, chin, jawline. 68-year-old, high smash facelift, 28 cc's of fat. Look at the improvement in temples, orbits, cheeks. Jawline. 53-year-old, very proptotic, bottom-heavy face, high smash facelift, 66 cc's of fat. Note the improvement in the eyes, cheeks, mouth, chin, and jawline. 67-year-old, high smash facelift, multiple procedures, including 68 cc's of fat. And a 75-year-old, multiple prior facelifts. Think for a minute what she would look like if we just did another facelift on her. High smash facelift, 90 cc's of fat, a dramatically improved appearance by restoring her lost facial volume. So in summary, skin is intended to serve a covering function, not a structural or supporting one. Skin tension flattens contour rather than restoring it. Skin tension results in pore scars, hairline displacement, tracheal distortion, and earlobe malposition. Skin is not capable of providing sustained support of ptotic deep layer tissue. SMAS is more closely associated with tissue layers descending with age. SMAS provides better repositioning of ptotic facial tissues. SMAS repositioning results in a soft, natural appearance by getting tension off skin. It gives us inconspicuous scars and extended lifespan of the procedure and allows us to repeat a facelift without creating a surgical look. Suspension sutures are not capable of producing uniform or sustained support. Fillers cannot overcome tissue ptosis and skin redundancy, and skin surface treatments don't address deep layer problems. Traditional low SMAS flaps suffer the drawback that they can't, by design, exert a significant effect on the midface and infraorbital areas, but planting the SMAS flap high along the zygomatic arch overcomes these problems, produces an improved result. For most patients, repositioning of midface tissue obtained with a high SMAS flap will be satisfactory, and no additional or separate midface lift procedure will be required. Fat grafting allows treatment of age-associated loss of facial volume not addressed by facelift surgery. Fat grafting works best when sagging tissues have been repositioned and redundant skin excised. Simultaneous facelift and fat grafting will provide a better result than either technique performed alone. Fat grafting is an artistically powerful adjunct to a facelift that results in a more healthy, fit, youthful, sculptural, and central appearance than facelift alone. Fat grafting may result in an improvement in skin quality mediated through a stem cell effect. Patients with full faces often have regional atrophy and can still benefit from fat grafting. In many instances, fat grafting can replace or preclude the need for facial implants. Incorporating fat grafting into your facial rejuvenation procedures is arguably more important than what facelift technique you use. Fat grafting is often more important to rejuvenating the secondary facelift patient than the facelift itself, and these benefits may offset the drawbacks of increased operating time, uncertainty of graft take, and a longer period of recovery. So thank you very much.
Bill, do you want to come up? I think Jason may have had to go to catch a plane, so I know he left us his email. And so we have about 10 minutes, 10 to 15 minutes. Well, that was a wonderful session. And if you have questions for any of our speakers, you can make your way to the mic. Hey, Bill, let's start with you. So Tim nicely showed us how he marries his facelifting technique with fat. And it looked like on most of your patients, they had some facial surgery as well. So what are you doing to the midface to kind of support that lower eyelid and the fat grafting that you're doing?
Well, my philosophy is a little bit different. My facelift's a little bit different in that I really focus on the shift of tissues. So I'm working directly on the area of excess that we think of as the gel, and I'm moving it directly up. So I don't do as much fat grafting to the face. I do in a quarter of patients, and there it's critical. But on people in whom I see this shifts more as a gravitational shift rather than an atrophic one, I don't graft the face. I graft the lids and the lips in virtually everybody. So it's a little different, just a little different take. But on the patients who are thin and gaunt to begin with and don't have any reserve from which to lose anything, then yeah, they need fat grafting in the face. It makes all the difference, as you saw beautifully just now.
If I can add to my lecture, The mistake we've made is we've been calling the aging deformity of the upper cheek the wrong thing. We've called it midface ptosis, and that made us think we had to lift. But if you look at those patients who are claimed to have midface ptosis, they really have midface atrophy. It's that their midface is hollow and atrophic, and it's far more productive to rejuvenate the midface by filling it than by trying to lift it.
Peter?
Yeah, you guys both showed really beautiful results of the correction of the tear trough and shortening that lower lid height with fat grafting. And Tim, you pointed out that you want to inject from below, sort of directly superiorly. Can you both talk about, can you elaborate a little more on where you put those port sites? Do you put them in the nasolabial fold or just in the cheek? And can you both talk about the different layers that you put the fat in to get that beautiful correction of the tear trough?
I went over it quickly in my lecture. You can make the holes wherever you want because they're so small they'll heal without suturing, or so make them where they're convenient for you. But the idea is that I think Bill advocates this too. Doing the lower eyelid, it's much safer to come up, much better to come up vertically from below, perpendicular, rather than from the side. Think of it as creating hundreds, if not thousands, of little tiny pillars supporting the lid. While you're doing that, you have your finger on the infraorbital rim protecting the ocular globe, because even though these cannulas are blunt, they still are capable of injuring the eye. But I think most experienced people injecting the lower lid figure that this vertical method is a safer and better method.
Tim, can I just ask, can I go just a little bit further? So as you're going vertically, are you breaking through the retaining ligament to put fat within the eyelid itself?
I forgot to say, you're on the bone. You're periosteal suborbicularis oculi. I think it's a mistake to inject more superficially until you're very skilled. And if you inject too much fat on the bone, you just open the lid up, go into the lid, and all the fat's sitting there right on the bone, and you recontour it. Whereas if the fat is scattered throughout the lid, you've got to delaminate the whole eyelid to fix that. So that's number one. And yes, number two, I think I'm feeling the needle going in and out of the orbital malar ligament, and by the time I've emptied three syringes of fat and gone in and out of that ligament, 120 times, it does feel to be partially lysed. But I assume also that ligament was present in youth, and I'm not sure we have to arbitrarily release it to restore a youthful situation. I think the filling is probably more important than any kind of release.
Okay.
I think it's a case where focus on anatomy actually can be harmful. There's great anatomic studies that show us these deep planes and how they communicate and all of that. But I don't think it has much impact on the way that I fat graft. I look at the needy face for fat grafting as a little bit as a sculptor looks at a clay model, and I don't worry about the anatomy so much. There's some rules you have to follow. Yeah, start against the bone when you're starting in the lower lid, but you can't get enough in it. It's what Roger said. You're trying to put too much in one place, you get a problem. So if you're going to get your mounts up, you've got to come up more superficially. Do the pre-muscle, the last of all. Sidney's doing that a lot because he's focusing on color, but that's your last goal in all of that. And in the upper lid, and I think Tim pretty well, he agrees, it's almost all against bone. I mean, you don't want to come off bone into the soft tissue of the lid. It's self-defeating, and limit your amounts there. I don't want to do much more than about 2.5 at one time. I'll come back and maybe do a little bit more later. The idea of working toward the globe, I think, is quite important. A structure like the labiomental crease, too. It's you go at that thing from the side, which is the logical way to do it. Invariably, you end up with a tube because you're putting all your fat along a certain linear track, whereas you go across it, the chaos theory comes in. You're trying to deposit in the middle as you cross it back and forth, but you're not good enough to do that, so it goes everywhere, and you get a much better blend with the other tissues. So take advantage of chaos when you can.
Some surgeons have advocated sort of a refilling of compartments, just like a bolus injection, and I don't think that's the right way to do it. I don't think that's a proven technique yet. Think of the face as a sculptural entity, and just put the fat where your eye tells you it's needed, and ignore what's happening below that. I don't know that the compartments are interesting and may prove to be useful. But I think in our current state of fat grafting, it's really a sculptural, artistic pursuit and not one of simply filling a compartment.
So you two are what we would consider the best of hands. What percentage of your patients do you bring back and put a little bit more fat in after their first round, would you say? Bill?
Well, that's a good strategy when you're learning how to do it, and you tell your patient that's part of the routine, and don't charge them very much when they come back because you're learning how to do it. I used to tell my patient, I would say 40 to 45% of my lower lids was a second procedure. Now it's very unusual, except that what Peter brought up is that a certain percent of patients just don't, the fat doesn't work as well on them. And I tell my patients, 10 to 15% of patients, I can't identify them ahead of time. It just doesn't seem to work as well as everybody else. So that's a group where you're going to come back and do that. But start off doing it. Don't try and do it all. The big sin in all of this is over-grafting. Over-grafting, and now you have a disaster. Undergraft, and you come back and you do a little bit more, and you learn. And that first movie I showed was a patient back when I told her, yeah, this is going to be 2 times. I almost never tell a patient it's going to be 2 times unless they have a real scar problems or something like that. So you get better and better at it. But the other hand is your patients become very, very, they become fat addicts, and you need to put a break in somewhere so that somewhere in your written material, you have to put that additional fat grafts will incur a small additional fee, or your patients will never stop asking for a little something more here, or a little something more there, or something more there. So be careful of that.
Tim?
I think most patients get what they want in one treatment. When I think, 15 to 20% of rhinoplasties need revision. Probably 40% of breast implants at some point need some kind of revision. Probably 25% of abdominoplasties need a little touch-up, lipo or dog ear. 15 to 20% of everything we do requires touch-ups. And I found that fat grafting I'm touching up much less than other things I do. And usually it's not a lump or a problem. It's just a patient saying, I want a little more of a good thing, which it's good to undercorrect and add more than to overdo it. The other thing is you're chasing your tail if you're only trying to fill the lips or the nasolabial folds. You have to look at atrophy as a pan-facial process, and the real power in fat grafting is making nuanced changes over multiple areas of the face, not just making big lips. Making big lips on an atrophic face just looks silly, and the real power of this procedure is to make small changes over multiple areas.
Alfonso.
Excellent presentations by both of you, and I just had a couple of questions for Tim. Your necks look so good, and I wonder what percentage of your cases do you do submaxillary gland resections?
Well, it's a whole lecture which I would love to give to you because I think, if we fail in the neck, patients think their whole facelift is a failure. The patients put a high priority on a good cervical mental contour. And it's a matter of diagnosing the problem. We've traditionally approached the neck as if the problem was subcutaneous, doing liposuction and tightening the skin. If you look at the young neck, it's actually plushly padded, and you can't see any of the underlying anatomy, and we've been kind of skeletonizing the necks, working too superficially. In the aging neck, most of the fat is subplatismal. Over the years, I've evolved from being very judicious about subcutaneous fat to getting to the point now where I almost take out no subcutaneous fat because it's actually precious stuff. It's like septal cartilage. But I aggressively go after subplatismal fat. But if you do that, you're going to make the submandibular glands more obvious, and then that usually means you have to knock the bottom off of those. And then if you do that, then sometimes the digastric will sit up a little high, and you'll have to shave that down. So the real secret to those good necks is recognizing the anatomic problem present, not thinking you can just tighten the platysma over those problems. That'll make a temporary improvement, but not a sustained one. And then if you diagnose an anatomic problem like a large gland or subplatismal fat, then you have to employ a logical solution to address those problems, and I don't think tightening the skin or this mass, tightening the platysma or skin is a logical treatment of those. So it's very common. Once you get good at putting a columellar strut in, you put it in most of the time because you want that consistency. So I would say in 9 out of 10 cases, we're doing some reduction of the gland and that deep layer neck work because I want that result. Patients prize that result.
And once you've done your high smash lift and mid face lift, it seems like there's a bit of recruitment of skin toward the lower eyelid. So I suppose you often do a pinch blepharoplasty in those cases?
If you do a good job on the midface, you generally push a little tissue into the lower eyelid. So sometimes that'll require traditional skin excision, but often you can clean it up with the laser or TCA peel if it's a more minor push.
Great. Thanks a lot.
You're welcome.
Well, I want to thank Tim, Bill, and Jason for a wonderful session, and I'll give the mic back over to Bill and Peter for final words.
Okay. Well, that concludes the 11th symposium. And I want to have a round of applause for all of our great faculty members here. Really incredible talks. And I want to thank my co-chair, Dr. Bill Little. It's been a pleasure, as always, putting these great programs together. And thanks, Bill, for all your contributions also. Bill, do you have any words?
Just to say that, I learned so much today. Today was a great meeting. I learned so many new things. And you get to a point sometimes where you don't so often. But boy, did I learn a lot today. Some of it from you, Peter. Thank you.
Great. Well, thanks again to all our speakers, and thanks for all of you for attending this great day.